at the end of the 3 days. Okay, beginning this 3-day journey, I would just like to ask a small question. Do safe and effective vaccines save lives? Yes or no? Do safe and effective vaccines save lives? Okay. We need to add a little bit to that it is vaccination which will save lives. And if vaccines remain in the cupboard or in a box, no matter how safe or effective they are, they will not have any effect. They have the potential, but we as human beings have to use that potential. Likewise, the latest TB screening and diagnostic tools will help in saving lives only if we deploy them closer to the people and closer to the most at-risk people. The only pathway to deliver state-of-the-art TB screening and diagnostic tools, as well as treatments, to the most at-risk people has to be grounded in people-centric, right-based, and gender-transformative approaches. And as you all know, you all are stalwarts who are working in your countries to achieve that. We have all the diagnostic tools, but still we are not deploying them in innovative ways close to the people. And unless we do that, how can we find all TB, put all of them on best treatment, and prevent all transmission of TB through people-centered pathways? Now, this hybrid meeting is being organized jointly under the banner of Global Call to Find All TB, to End TB. It is being organized by the Global Call to Find All TB to End TB, by TB People Zimbabwe, by TB People India, and CNS with support from Malbio Diagnostics. I would now invite Tariro Kudatsa, TB People Zimbabwe, who has come all the way from Harare to support our cause. Tariro, please come.
Thank you so much for the opportunity. I can just say welcome everyone, and also I'm welcoming myself, because this is my first time to be in India. From the KVP voice, normally we don't feel okay if we don't chant our slogans. So yes, we can end TB. Yes, we can end TB. So the reason we are here, I think all of us, is we want to end TB, and this is achievable, and we can do that. But how can we do that when diagnostics are not to the people? I think I always challenge scientists, mathematical modeling and so forth, to say, how can you miss a person? How do you miss children? We are there. We are there with our TB. We are there. Us from communities, we are there. But the only missing link is the diagnostic. So bring diagnostic home, bring the diagnostic to the people, and we can end TB. And also the other issue that comes with it is just because people are not diagnosed. The stigma, the other services, they all come in place as long as people are diagnostic with the simplest ways, and to the people where we are, in our artisanal mining, in our tobacco farms, in our congregate mine. So bring diagnostic home. Thank you so much.
Thank you, Tariro, for your energizing words. We also have Tarit Chakrabarti from TB People India to share his thoughts briefly. Tarit, please.
Good morning, everyone. My name is Tarit Chakraborty. I'm basically from West Bengal. In the year of, actually, the thing is, in the year of 2001, I'm tested HIV positive. In the year of 2004, I was tested, I'm a TB infected person. And again, I have got extrapulmonary TB on spinal cord, and that is on 2009. So anyway, the thing is, during COVID, we came together, all the HIV infected person, and made this forum that is called TB People India. So if we see the line, United Against TB, accelerated action towards achieving SDG on tuberculosis, the line starts from United, unity. So what we believe that we need strong unity, then only we can eliminate TB. Everyone's engagement is very much required. It is from healthcare provider to the political commitment is also very much required, as we believe. And the second, but the last thing is, I must focus on this thing that community engagement means meaningful community engagement, because we want to raise our voice from our own, actually, not through the second one. Then only it can be fruitful, like HIV program has done a big achievement. So that is the thing I wanted to say. There is some time shortage. That's why I'm finishing my words. Thank you all.
Thank you, Tarit. I would now request Dr. Kuldeep Singh Sachdeva, former NTP manager for TB and HIV in India. He had been Deputy Director General TB, Ministry of Health and Family Welfare, Government of India, and our guiding force. And currently President CMO, Molbio Diagnostics, to please elaborate on the objectives of this 3-day meeting. Over to you, sir.
Thank you, Shobha. Good morning and welcome to all of you to this meeting. Before the objectives, I think I'll lay down what has changed in TB over past few years and why are we talking of TB elimination now. And if you search, say, Wikipedia or look at how long TB has been existing in this world, it is almost 20,000 years. 20,000 years. Okay. Did we talk of TB elimination earlier? I mean, the first bacillus was discovered in 1882. First drug was discovered in 1945. So there was nothing available for almost 19,000 plus years. And most programs in the world were TB control programs. You all know that. Nobody talked of TB elimination. So what changed in, and in all of you, I mean, we are all adults and 40 years, 50 years. I mean, I see the average age must be around 40, 50. And we started hearing about TB elimination in last, I think, 5 years plus. We were not talking, even I was when a program manager at India for the National TB Control Program. We never actually thought of TB elimination there. So what changed? Few things changed. You heard just 2 people. So there is a lot of openness to talk about TB. You heard TB people. So there is a lot of activism to talk about TB. There is a lot of advocacy to do something for people. So that's one thing which has changed. The other is the discovery of diagnostics which are very sensitive and specific. We all know sphere microscopy used to miss 50% of patients, so we never thought of eliminating TB. We thought of eliminating TB when we were very certain that there are mechanisms now by which you can diagnose everybody. So the science enabled you to diagnose everybody, but the other part of which implementation was not enabling you to do that. You could not reach to everyone in the society, remote parts of the country or areas which are inaccessible. That was also made possible through a mixture of implementation science and again, diagnostics which are now very small. So you can take them to periphery, you can do testing at your home. So that changed. Another thing which changed is availability of very good drugs. If you diagnose somebody, you are sure you can cure it 100%. I mean, almost 100%. Drug-resistant TB used to be a big issue. Now you have a regimen which cures you in 6 months. We never thought of it. We used to dream about it. The treatment was for 2 to 3 years earlier. And it's not very far. I mean, Dr. Ashwini Khanna, Dr. Chopra, most of you who work with programs have struggled with it. Patient will drop out of treatment because 2 years, 3 years injectable, it used to be very painful. So science has given you now diagnostics, drugs. Implementation science has given you to reach the remotest part of the country. The community has given you the visibility and they are open to talk about this thing. And the partnerships are now more, we see more and more partnerships now. People are now ready to get together and do more. So you see people from other organizations, many people are not representing the national program, they are representing the civil society, they are representing donor. I see Amar Shah from United States Agency for International Development here. So USAID, Global Fund, World Bank, Asian Development Bank, and so on and so forth. They have come forward to support the cause. So there is a funding available now. We have to, what all we need to do is we need to now channelize this energy to get things in a proper way that we can do that. And soon we will also see prevention being widely available. So we are almost there for a vaccine. You will soon have a vaccine in another 2 years or so. Globally, you will see a vaccine being rolled out. So now you have practically everything from science, everything from the community, everything from the partnership, everything from implementation science, and also from political leadership. You have India committed to eliminate TB 5 years earlier. So did Timor-Leste, so did many other countries. Most countries are committed to eliminate it by 2030. So when we say 2030, these are advocacy targets. People give you a target so that you'd work more, try to be there. So it doesn't mean that it has to end in that particular year. We said health for all in 2000, but we are still working for it. India said polio elimination by 2000. We eliminated polio in 2013. So those are implementation challenges. The things will happen. Once you decide and there is everything available, I think we'll eliminate it. It's only a matter of time. And if we keep going on it, I think we'll be able to do it. So that's the positivity which I wanted to bring to this group, that it's doable now. We have science, we have implementation science, we have partnerships, we have people who are working for it. So now coming to the objectives of this meeting. So we titled it as United We Stand Against TB. I think we all unitedly stand against TB. So there is a complete agreement on this. And what we are saying, if you can find TB, then only you will be able to cure them. If you cannot find, you cannot cure them. So now, as I said, there is a lot of developments in science and other fields that you can actually reach out to all people in the remotest and farthest corners of the world and find them and treat them through implementation science and through better diagnostics. So our basic objective is to discuss, deliberate, and find out ways how we can suggest to the UN meeting, which will be held later this year in September. What is that this group wants them to commit and to push for is that let's first as a first step, let's reach out to everybody. Let's find all TB cases. And that is what we are going to deliberate. And we will present some country examples, some possibilities, and also hear your thoughts and see how we can actually suggest some actions for other donor agencies and the people who matter, key opinion leaders, to sort of clearly articulate what needs to be done to end TB. And I firmly feel, and as a even as a earlier program manager who has worked for TB passionately, so that we'll be able to do that within a limited time span, and there is everything which is available to do that. So that's just one basic objective. How do we do that? So we'll deliberate that in due course of time. Thank you for your attention. We'll keep interacting in the meeting now.
Thank you, sir. We have with us today two stalwarts to deliver the inaugural keynote addresses on where we are in our journey towards TB-related SDG target and what is needed to achieve it. Our first speaker is Dr. Suvanand Sahu, Deputy Executive Director, Stop TB Partnership, who has kindly consented to join us online from Geneva at this unearthly hour for him. It is early in the morning there. Welcome, Dr. Sahu. I hope he's online.
Thank you. Hope you can see me and hear me.
Yes, we can.
Yes, very good. Thank you. Good morning and greetings from the Stop TB Partnership. As Sobha said, it is indeed quite early here, 6 a.m. now in Geneva, but happy to be connected, and thanks for inviting me to share my views on this topic. I can imagine there in Goa, lots of people in that room I saw. So it's good to see all of you there, some known faces as well in the meeting. I will use a few slides to go through what I was told to talk about. And this is about where we are in our current journey towards the SDG targets that we have for TB and what is needed to achieve those targets. So if someone can indicate that you can see my screen. Okay, I see, I think somebody's hand. Yes, so I'm going ahead. So let me start by just focusing your attention on what was agreed as the target for the Sustainable Development Goal in relation to TB. This has basically two targets. One is on reducing TB deaths by 90% compared to where we were in 2015. And the second one is reduction of TB incidence rate per 100,000 by 80% compared to where we were in 2015. So as you can see on those two graphs, the TB incidence rate per 100,000 has declined over the years. We saw a reversal of that during the COVID pandemic, went up slightly. These are WHO estimates. We don't know how it will go forward, but we are hoping that it will again go down. It will not go further up. And I will present to you some good news about what countries are doing currently to make this happen. So it should come down. However, note that even if this line comes down at the same rate as it was coming down before, it is going to hit in 2030 a place which is far off from where we should be, which is the 80% reduction in the figure from where we were in 2015. So we are actually off track. We are off track on this indicator. Look at the TB deaths, similar story. there was a decline, the reversal for COVID, and it has started actually to decline again because WHO did estimate that for the last year that WHO had the data, it had declined. But even if that goes forward and business as usual continues, we are going to miss the target for 2030 for deaths, which is here in the red. So one thing we have to say very clearly that related to the journey towards the Sustainable Development Goal TB targets, we are off target. And what is needed to be on track to end TB? Now, I'm just taking the example of incidents, but you can also do that for deaths. Now, this is the line that you saw, where if business as usual continues, where we will be. Now, what is needed? We need to bend that line that you see, the line here that is dotted line, that is into the future. It cannot go the same way as in the past. We have to bend the line here and bring it here. What will make us do that? If we just do some slogans, maybe not. But if we do some good, high-impact interventions, we can bend that line. The science is there. And we need some heavyweight interventions that currently we are probably doing under scale, not at full scale, or new interventions that need to come in. And let me just talk a little bit about, in a very simple way, it is more complicated than what I will present now, but this is what we had also presented to the Stop TB board earlier on this year. So what are the things that we need to do to get this line, not here, but here? First, we need to find and treat all TB. We all are aware that millions of people go undiagnosed, untreated globally. Thousands, hundreds of thousands in some countries, big countries. So they have to be all found and treated. Is that enough to reach the targets? No, but that's the first step. And that's a big step. Imagine millions of people getting diagnosed, treated, not dying, and also not transmitting the disease to others. One other thing that we have to do, and very important, and a lot of evidence to show that currently the people that are getting diagnosed with TB are actually getting diagnosed late. What is the implication of that? That means they have already spread the disease to the contacts, to household contacts, to social contacts. So TB is an airborne disease. We have to, if we are able to diagnose them before transmission happens or at the early stage of transmission, that will have a bigger impact. So what are the things to be done to get early diagnosis? They are probably different from just finding all TB, all people with TB. This will require the health system to be active, to reach out to people before they start symptoms or at early stage when they are just beginning to start with symptoms. I will draw your attention in this context to a recent publication, which for the first time has defined that TB is no longer just latent TB infection and TB disease. No, there is an in-between stage now defined and called as subclinical TB. Here, the clinical symptoms are either not there or the person doesn't appreciate these symptoms and therefore does not seek action, health-seeking action. So we need to reach out to such people. We also will need better biomarkers and better diagnostics to do that. And it is possible. There are some things in the pipeline. So the second point I'm making is early diagnosis, not just reaching all people with TB, but reaching them early. The third, very important, is preventing people who have already got exposed to TB. For example, household contacts. There is today, not today, but there is science, not very new, old science, which can actually prevent and protect the people who have been exposed to TB. And this is TB preventive treatment. So the guidelines internationally is that contacts of household contacts of people with TB have to be screened. Active TB has to be ruled out, and then the rest have to be put on TB preventive treatment, either following a TB infection test, or if the test is not available, everybody who is eligible. How are we doing? It has not been scaled up. If you look globally, we failed to achieve even a reasonable figure on that for the last UNHLM target, which was for the period 2018 to 2022, set in the UNHLM 2018, not 2023. So this is something that we have to do better and scale up. I must recognize here that the world did good in providing TB preventive treatment to people living with HIV, which is another group, which is important. And the target was achieved. But for contacts of people with TB, the performance was very poor. We have to do more on this. There is a tool available to prevent people from developing TB. We are not able to use it, and people are not able to access it. So that's the third one, the TPT. Then next, very important in the bucket of prevention is nutrition. 1 in 5 TB globally is attributed to undernourishment. This is WHO estimate, and in some countries it is even higher. In this country, in India, where we meet, it is even higher. But India has also shown in a clinical trial that if you provide nutrition to contacts of people with TB, you can reduce significantly TB incidence amongst contacts. If I recall correctly, something like 40% reduction, 40% reduction of TB incidence amongst contacts in just 2 years. We saw the decline in incidence curve. We are not happy with it, very slow. This is an intervention which is not even a medicine. It is available to all. Why can't we do it? Some countries have done good work on it. So far, we have been focused on providing nutrition to people on treatment, TB patients. However, we have to take the next step and provide nutrition to those who are exposed to the disease, for example, contacts and other vulnerable groups. So nutrition is another heavyweight intervention that can draw the curve down. Next, I think everybody is expecting vaccine to come, and yes, indeed, it will be at some point. We have 16 plus vaccine candidates under clinical trial, 5 of them in phase 3 clinical trial, including in India and in a number of other countries. So results are expected, and once vaccination happens, that's a big task that will add to the prevention bucket of TB. So I wanted to highlight a few. This doesn't mean that this is an exhaustive list. I will come later to what we need to do as a comprehensive package to end TB, but these are some of the heavyweight interventions that can actually pull down that curve that is not going in the right direction. It is going the right direction, but not enough pointing towards the target. So we do need interventions that can diagnose. We often call it as an acronym for Stop TB Partnership: search, treat, prevent. So not just diagnose, but search people and find them and treat them. And then very important is prevent, which we have underused in the past. Now, coming to that, those were some things that you could do and see from modeling and so on. But now coming to some real life experience. We are, you see, in terms of the results available, we are in 2024, but the results available are not for 2024, but 2022. So we are 7 years down from 2015 when the SDG agenda started, and another 7 years to go. If you look at countries, how they have done, I have not named the countries here, but if you look at the graph here, TB deaths decline in 22 out of 30 high burden countries. The others, there are some issues with estimates. But if you look at the decline, various, it is not a global decline, you saw the average, but you see some countries have reached close to 80% decline in 7 years. Why can't they achieve the Sustainable Development Goals? I must say a lot of them are in Southern Africa. And a lot of that can be attributable to the reduction in HIV, ARV scale up and all. But there are also other countries in other regions who are showing a good decline in incidence. Sorry, this is for deaths, and this one is for incidence. Similar picture, you see a number of countries reaching more, close to 30, 40, 50% decline in 7 years. So why we cannot have it in next 7 years, the rest of it? So some countries, yes, it is possible, more possible than the other countries. But business as usual globally will not lead us there. These countries are doing some extraordinary work that we have to do it in many more high burden countries. This graph on the right top also shows us historically, even when tools were less developed, countries have achieved this. This is in Alaska in United States, rapid decline of TB. But what was done was a comprehensive scale up of interventions. We have similar picture. I didn't have space here to put many other countries. Just a week or two ago, the new minister of Japan was in Geneva, and he elaborated how in 1950s, Japan brought down the TB rates in the country by assigning a special budget to it and making it a pathway to UHC. And they did it in 10 years' time. It was a rapid decline in Japan. So a number of examples are there. So it should make us feel confident that we can do it, provided we don't continue business as usual, but we do more things and more things to decline TB. Just to inform you, for those who are probably not aware, there is a global plan to end TB. This is exactly talking about what I talked with more details. And this is for the period 2023 to 2030. It also estimates not just what we need to do as a comprehensive investment package, but how much will it cost? There is a price tag to it, and I will come to it later. But it also covers many other areas. It also gives you a return on investment. If you have to do advocacy to get more funding at the global level, these figures are available. If you invest in TB, or $1 gives you how much in return, and I will come to that. And this can also be repeated at country level. So the global plan, in fact, shows through a set of modeling and some examples from countries that, yes, it is possible to reach the targets for sustainable development goals for TB. Now, if we reach there and the investments are made in TB, what are the gains? What is the return on investment? It is huge. $1 invested gives you $40 in return. And if you see, most of the return will be in, will accrue over a period up to 2050. And if you do that for low and middle income countries, the return is even higher. I haven't shown it here, but it's even higher. But on the contrary, if the funds are not invested, what happens? The global plan has this quantification also done. The cost of inaction, not investing, is expensive, very expensive. $1 trillion is in terms of lives lost and productivity lost. So huge cost of inaction and very good return on investment if you invest on TB. In 2023, I'm not sure if somebody was in the room in the UN high-level meeting that happened in 2023, September. I was there, and I think many TB stakeholders were there. A political declaration was endorsed. This political declaration is now available. We must remember that all countries, all member states of the United Nations have signed up to this political declaration. I must say the targets and commitments in the political declaration are very bold, very good. The challenge is how do we implement them? And I will come to that a little bit now. So some of the targets there, very concrete in terms of numbers, numericals. These are people. These are not just statistics. So 45 million people to be treated for TB between 2023 to 2027. And these are global figures. And I'll come to the share that each country has to make the world to achieve these figures. If you just think that the world will achieve, it will not happen because the treatment happens at country level. We also have treatment for target for children with TB, as you can see there, target for drug-resistant TB. And I will come to a little bit on that because the UN General Assembly in September is going to have a high-level meeting on antimicrobial resistance, and drug-resistant TB is part of it. Mark here that there is also a target for people to be put on TB preventive treatment, a bigger number than what was in the previous UN high-level meeting, and which was not achieved. So now it is even a steeper target to be achieved. So these are the global figures. What we have done from Stop TB Partnership is many people said they feel the language of the UN political declaration is difficult. It is a long document. So we have digested this into a simple document. There is no reason, there is no excuse actually not to read it. It's very simple, very short, which you can see on the left side there. We have also broken down the global targets through the same modeling exercise as was done for the global plan to country level, because the action has to be at country level. And at the country level, we have targets. You can see the link there. If you go to the Stop TB side, you can actually download your, you can download for all countries, but you can also download for your country what is the target. These are indicative targets. We appreciate if the countries have done their own target, but with the same kind of ambition as the global target for UNHLM. You can see there some countries have huge targets because of the burden they share. India, Indonesia, a number of other countries that are high burden, and the targets are hopefully when you scale up, you will reach more people with treatment. So that's how you see each year you have a higher target, but at some point TB should start declining when you reach all of them. So the numbers to be found and put on treatment in subsequent years will be less. That's a good scenario. If we don't act and continue business as usual, we have to continue to treat more people in the future, which is not good. Now, where are we in terms of those targets? You saw in 2023 WHO report, the data was there for 2022 after 2 years of setback from COVID. There were increases in TB notifications from almost all of the high TB burden countries. So in 2022, we reached the all-time high. It was all-time high globally, number of people diagnosed and treated with TB. However, we have to note that the UNHLM target, which you see in the lighter shade of blue, are even higher targets for subsequent years. We feel, and I will come to it in the next slide, we feel that 2023, we have some provisional data, some available through WHO and some directly from countries. We estimate that for the first time, global notification will go over 8 million. So that means from 3 million missing, we will have less than 2 million missing. And we will come very close to the 2023 target for UNHLM. But you have to remember that 2024 is even a higher target. So in 2022, yes, it was all-time high, but long way to go further. This was a big setback during COVID. A lot of people could not get access to diagnosis and treatment, and that also had a lasting effect on the increased incidence of TB. But we must here congratulate all the TB programs, partners in countries who have done very well, overcome the barriers of COVID, rebounded back, and now are performing much better than even the pre-COVID situation. But there is a long way to go in this area. Now, a little bit about what happens next. So when we look at ending TB, it is not going to be a situation where tomorrow is same as yesterday. What got us here will not get us to 2030. We have to be clear on it. We are seeing around us, life is changing. The past is not how we are going forward in the future. Many things we thought impossible in life, in computers, in handheld devices, things are changing and it is happening. Many things have happened in TB as well. We need to recognize that. This also makes us think that what we thought maybe 5 years, 10 years before as impossible is currently possible. Some examples here. X-ray screening was very difficult because you have to go to a health facility with a good infrastructure, travel some distance, go to a dark room, get X-rayed. The X-ray comes later, somebody reads it. Very difficult. Now, what is the situation? Countries are using ultra-portable X-ray devices, handheld devices. You can put it, deploy it anywhere in the community, in the peripheral health units. And artificial intelligence on reading X-ray as normal or abnormal, needing a TB test, that has developed to such an extent that it is outperforming human radiologists. Many countries I have engaged in the past is to say we have very few radiologists. It's impossible to scale up. It is now able, these countries are now scaling up. You get a result quickly, and then you can go for confirmation with a rapid molecular test. More such things are coming in future. AI is developing. There are apps to detect, not detect, but screen and indicate that you need a TB test from your cough, the nature of your cough. During World TB Day, we demonstrated such an app in Geneva, and we got quite an interest from people here. And I know that some countries are testing it out, including in India. There are also research happening on non-sputum-based testing, samples that can be tested with it, which are not sputum, because we know some of the difficulties with sputum. Also, some research ongoing on subclinical TB, how we can find biomarkers before symptoms arrive. We should be able to diagnose TB. We have seen a few years back, a number of countries also here, people used to say the only thing we can scale up is microscopy. No longer. Actually, the global plan that I showed you has not costed, it's a costed plan, right? It has not costed microscopy as a diagnostic. So the standard of care today is rapid molecular test. And these tests are growing in numbers. They are becoming simpler. There are also other technologies coming. As you may have seen, WHO has recommended genetic sequencing for drug-resistant TB in programmatic use. So great developments are happening in screening for TB, but also in diagnosis for TB. So there's no reason now to depend on microscopy and old tools, and we should be making possible things that we thought are perhaps not possible in the past. Imagine the treatment, 18 months of treatment for a drug-resistant TB. As Dr. Sachdeva was saying, injections, hospitalization. It is a 6 months treatment. Can you imagine 3 to 4 drugs taken orally? That's how we treat drug susceptible TB, completely ambulatory. So it is simplified, and research is happening to simplify further. Can TB treatment be done in 1 or 2 months? There are some things happening on that. Can a single long-acting injection treat TB? This is also being researched. So a lot of interesting developments are happening in the therapeutic side as well. A lot of development on vaccine. As I said, 16 candidate vaccines, 5 of them in clinical trial. I think 2 of them are very close to getting the data. And vaccination should be happening soon. Our board actually gave a target that we should start vaccinating 2028. And it was interesting discussion in the board with all stakeholders, including WHO, Gavi, Global Fund, country ministers. So we are in a very interesting phase. But as people have said, it is not the vaccine, but vaccination that will save. And by the way, the global plan has the estimates of what is needed to do the vaccination in terms of the costing, in terms of the scale up. Of course, assuming some hypothetical vaccine, but we will have to wait and see what type of vaccine, because each vaccine has different characteristics, different population eligible, and different impact. I must also highlight that not just scaling up, we have to do things in an equitable manner. TB is a disease that picks up, especially the people who are the underprivileged, vulnerable, marginalized. We have to do all we can to see that they have the best in access. They are the first people that are able to access these new tools. So a lot of things have happened in the area of what we call as community rights, gender. A lot of countries have done assessments and have come up with costed action plans. These action plans have to be implemented. Remember that there is also a target in the UN high-level meeting to end stigma, and we have to work more on that. There is also now a possibility of doing community-led monitoring. In the past, monitoring of programs were done only by the programs themselves. But now it is possible, even the beneficiaries or the communities affected by TB are able to give feedback into the monitoring process and are actually leading the process in many projects in a number of countries. This is called community-led monitoring, and there is a tool there, digital tool called One Impact, that is making this possible. So what is needed now to go forward? We will need a lot of political commitment. And we have seen over the last few years, a lot of political leaders, not just the health ministers, but some of the heads of states have spoken about TB. Here in India, in Varanasi, in March 2023, we had seen Prime Minister Modi speak about it. You can see the picture here of the president of Indonesia, who met us in Jakarta some years ago and started a program and a presidential degree on TB. Here you can see 7 countries' health ministers came together, mandated by their heads of states in New York last year during the UN high-level meeting, and committed to do more on TB. So we have now the leadership talking about TB. So this is a very good opportunity. When leaders talk and want to do something, we have to give them the tools to make it happen. And their responsibility is to provide the resources and the political will to make it happen. But we are in a very good shape compared to a few years ago. There is for advocacy, there is also a UN high-level meeting coming up in the UN General Assembly, not on TB this time, but antimicrobial resistance. And there is actually a multi-stakeholder hearing later today happening. I don't know if people are there from your countries, but we did support a delegation of about 10, 12 people to be part of that multi-stakeholder hearing. We have issued, from Stop TB Partnership, we have issued a key ask document. It went out as a news alert yesterday. It is talking about what are the key asks of the TB stakeholders in the AMR UNHLM. And here we are flagging a few things. I encourage you to read it. It is on our website. But there are many things we can talk about. Just to remind everybody that there are global estimates that 1.2 million people die directly associated with AMR, antimicrobial resistance. 160,000 of them are drug-resistant TB per year. This is per year. We must remember that 410,000 people is the last estimate of WHO get drug-resistant TB annually. And we must also recognize that most of them, more than half of them, never access care, not diagnosed, not treated. This is not a good situation. But those 410,000, remember, are just the rifampicin-resistant TB and the multi-drug resistant TB. There are resistance to TB beyond that, isoniazid resistance, more than double that figure globally. Pyrazinamide resistance, more than double that figure globally. We also must recognize that TB has an animal component, bovine TB in animals and zoonotic TB transmitted from animals to humans. There is an estimate of 140,000 people getting zoonotic TB each year. Mind you, each of this zoonotic TB is naturally resistant to pyrazinamide. So drug resistance in TB is huge, even bigger than the numbers that we have seen. And there is a big unmet need. In 2022, only 178,000 globally accessed care out of 410,000. So now I'm trying to wind up with a few things. What are the gaps that we should be aware of? Because it is always good to be in a positive mode, passionate to end TB, but we should be aware of the gaps that we have, and we have to do our best to fill it up. And these are some broad buckets, and if you go deep, there are many things. We all know TB can be prevented. diagnosed, treated, even cured. And a number of exciting new tools are there and more in the pipeline. However, this fact that we are facing today, 3 million people missing from diagnosis and treatment, this is unacceptable. They face different types of barrier. We cannot just sit in our health system and in a room in a meeting and imagine that they will come and get diagnosed. And we have to do more to reach out to them. We also have this issue that those who receive care are receiving too late. We have to do many more things to actively reach them early. Old tools are still being used despite having new tools. If you look at the WHO data, a lot of countries, majority of TB is getting diagnosed through sputum microscopy. This is not acceptable in 2024. This is like diagnosing and treating in the blind because it diagnoses about 60%, not 100%. Plus, it doesn't give you any indication to what regimen you should select. You can blindly treat them with drug-susceptible TB, but they may be deserving different regimen. So very important to scale up the new tools we have currently while we are waiting for new tools. And then inadequate funding is a big issue in a number of countries. I will highlight this in my next slide. But we have to remember that new tools, including new vaccines, are needed also to end TB. And research and development is also going slow. And that's a gap that we have to address. So this is about the funding, just to make people aware at the global level how we are doing. There is a major challenge. This is a major challenge. On the left side, you see here, this is UNHLM commitment, 2023, $22 billion for TB care and prevention per year to be made available. The last WHO report for 2022 was 5.8 billion, right? This has to grow 4 times. This is not a simple increment. And this is global level, but some countries are in a dire situation. Some countries are better off. Where we have seen there is good commitment from the government, domestic funding is available, the gap is less. Look at the research and development. This is also a UNHLM commitment signed off by all countries. $5 billion per annum is to be made available. The last report that Stop TB did with the tag puts it at 1.1 billion. So big gaps here. So we have to do more of it. And when you look at numbers of TB getting diagnosed and treated are going up, countries' notifications are going up. We are aware of some situations where Global Fund grants just have money for 2 years, not for 3 years. The third year, there's a huge gap. And these countries are some of the countries who are dependent on Global Fund. So this feels like when you go to a ATM machine and it says out of cash, probably we may end up there, not everywhere, but in some countries, in some settings. So very important for us to work on resource mobilization. And when we discussed this in a meeting in Manila, and we will do more such meetings to translate what is needed for the UNHLM commitments to translate into action, 3 things came up very clearly, 3 big buckets. We have to do more of awareness. I don't know if people in Africa recognize this picture. This is Biflo, a star there in a country, probably known in other countries also. So he's done some work. We know a number of celebrities have got involved in TB, but politicians, leaders, celebrities, we need them for awareness. People have to know that it is a big problem. TB is a big problem in the country. People have to know the gaps in the country. People have to know the commitments of what their leaders committed to in the UN high-level meeting and what actions are needed to end there. So awareness is very important. Second is financing. As I said, we should not end up in a situation that you are facing an ATM machine with which doesn't have cash. This is a time, opportune time that financing has to be scaled up. We have seen very good examples here in India. With the involvement of the Prime Minister, the funding went up significantly. This year and last year, we saw in Indonesia, funding going up significantly, not just a few percentage, but a few times higher. And we are working with some countries to make that happen in more countries, but more of this is needed. And then finally, on the third bucket is a number of actions to be done. Very often we think about biomedical actions, but there are many actions that are needed beyond that. That picture there is actually the Indonesia health minister who gave himself and his people a target of getting 8 million people notified from Indonesia when Indonesia was notifying to WHO 5 million people. That's a significant jump. People did not believe it will happen, but he did achieve it. He used to monitor it every 2 weeks. And they did achieve it. And this was a TikTok video that they put, a great way of making things happen through close monitoring and political commitment. So actions can be diverse. Every stakeholder has his or her ability to act, and we must unite and act together. Thank you. That's all from my side. Wish you a good meeting.
Thank you very much, Dr. Sahu, for giving such an exhaustive overview of what is happening, what needs to happen more, and what the future pipeline holds for us in our quest to end tuberculosis. I am now indeed honored to welcome Dr. Amar Niranjan Shah, Division Chief of Tuberculosis and Infectious Diseases at USAID, India. I have known him since more than 10 years and have always been struck with his simplicity and acumen. Over to you, sir.
Thank you so much, and very warm good morning, and really welcome again all of you to India. I think we are really privileged to all of you to kind of come here and share your kind of learnings with us. As I think mentioned, I am Amar Shah, represent USAID India, and as you may be aware, so USAID works in more than 100 countries, and for all high burden TB countries, we do have a support system in place, and we are really committed for this cause. I think our Dr. Sahu has beautifully outlined on where we are on the SDGs, as well as the broader strokes on what needs to be done. So maybe what I will share now, maybe around 10 points, which is I think a food for thought of what we should kind of practically do using this kind of a yardstick, as well as the principles which is outlined. And so maybe I have jotted down a few points, and then maybe I'll go through that. So I think, and maybe you can refer that that was a beautiful graph of bending the curve, where he kind of started with the first point of the find and treat all. So let's say if we want to do that, find and treat all, using the existing tool. So what now we have some of the demonstration sites, and I think what you can imagine a situation that the systematic screening can be established in a geography, where you can think of that we have a systematic screening going on. Everybody is getting screened either on symptom, number one, or AI-based. Let's say there are some prioritized cuff AI solutions which are also there. So you can use those. It's because they are just used as a aid to the kind of, they are not confirmatory tests. They are aiding to the screening test. So they don't require that much of a WHO pre-qualification benchmark. So you can always use that, because based on that finding, you are not putting someone on treatment. Also the X-ray AI. So let's say you can imagine a situation where any person positive either on symptom, AI, or X-ray, they are subjected to the molecular test. Then, if that person turns out to be TB positive, then you put on the TB treatment, or negative, because now you have the comprehensive idea about that population. The guideline also suggests that you can go beyond the household contact. So that person is, if it from the vulnerable community, actually you can test for the kind of TB infection, and actually then treat on the TB preventive treatment. So that completes your cycle of what I think Dr. Sahu was mentioning, that find and treat all. So when we say find and treat all, it doesn't mean only treat for the treatment. It is treatment for the infection also. And so that find and treat all also includes the TPT. So these were the 2 points I combined. Second, I think he really pointed out on the molecular diagnostic at the decentralized level. And this is something which we really want to work, that we have fantastic decentralized instruments available. And maybe I'm sure there are some field trips today as planned, where we will also see on the ground where how this is being used and some of the manufacturing sites. But so we really need to catch those things. Thanks, maybe due to COVID, now we have awareness about this thing. Like we now know that when we started in the COVID, there were no tests available. And then by the 1.5 year, everyone was having a test available at their home, wherever they feel that they can do the screening. So I think that's the thing where we really want to see. Also, third point, so now first, second, third is over, and the nutrition support. So nutrition support, we really don't want to continue this as I'm sure most of the time it happens in that way, that a TB program actually wants a find and treat component. But certainly the nutrition support should not be also rested only to either the Ministry of Health or the TB. What we really want is a partnership with the other line ministries, so that this nutrition support, not only to the TB patient, I think that ICMR study was being alluded, where we can also have nutrition support to the household contact of the patient, because that really prevent almost 40% of the TB incidence among the household contact alone. So this is the practical way of providing nutrition support at scale. And we can also use some of the innovative method where engaging again with some of the corporates, some of the partnerships option where this can be extended. I think one point was he made on now I'm moving on to the fifth part of the vaccine thing. There are 16, as he pointed out, 16 are in pipeline, actually 5 are in the phase 3. See, what happens in this kind of a situation where most of the time, and we have also witnessed in the COVID also, vaccine availability alone doesn't kind of solve the problem. We really want to have a larger uptake of the vaccine, and also each country, I think, have a different protocol of the approval. So my suggestion would be that we can have a vaccine demonstration consortium. So basically, you can think of this as a one-stop kind of a solution where this kind of manufacturers, then all the maybe risk investors, they come together for either technical, administrative, implementation, facilitation, and maybe also for some of the domestic manufacturing, and then deployment and the validation of the product. So this is one area where alone one player working just on, because they are passionate, right? They really want to discover the vaccine. But then we have seen that unless it is linked with the later on the production, validation, and the in-country approvals, and the associate awareness activity among the community about the TB vaccine, this is a hard task. And some of the countries we have seen that they have already start this thing. So maybe developing those consortium in future will really help fast track. Now the sixth point I want to touch is some of the disease surveillance component. And I think that's getting more and more importance now, because what we talked here was a national level targets, right? But we now know that disease elimination doesn't happen at national level if you don't work at the subnational level. And to do that, you really need to have a intelligence at the subnational level. So what we will require, and I think Dr. Sahu also alluded to some of the AMR component here, going forward, we really would require a continuous surveillance network at subnational level. And you can think of involving both the component of, let's say, epidemiological, molecular, and also the environmental part of the surveillance for the all form at the laboratory, hospital, and community settings. So it really should not just rest at the lab level. The community setting level data is also paramount important. Seventh, I think, which is growing, and maybe we are all passionate about TB. We always want to see this government going on. But in pure public health definition, TB is still a rare public health event. And in that case, just getting a verticality is not going to help. And most of the time you have seen that primary impact. So this is a comprehensive primary care. And once you deploy that comprehensive primary care, that actually alone improves. So TB is part of the primary care. I'm not saying it's not that. There are 12 components of the primary care and TB is essentially part of it. But rather than riding on alone, we really want to make sure that like whichever our support is, whether it is also contributing to the primary care. That alone will actually help you to reduce the TB deaths as well. So once you reach the saturation level of TB services by 80% in any community setting, along with the primary care, you can reduce the death in general at the population level. So maybe for your country, you really need to see half of your population, 50% of your population, what is the age kind of death. So startling to see that now some of the still countries where 50% of their population die before the age of 50. So we really want to make that causality analysis and TB will be there. So I think riding on the primary care and supporting that really important. Eighth component I really want to see, and I think Dr. Sahu also mentioned that about the AI, but I also want to expand it little that like this is the age and DNA where we really want to have the better grip on the data, the HMIS. For all individual countries, I think we have come a long way. I think he showed that computer, laptop, and tablet. Similarly, on data management system, we have come a long way from the paper-based recording system to now the electronic channels. In that also, we really want to see whether we can, at the population level, can have a measurement of the longitudinal data. So there are, and that's why our effort should not be on just developing some siloed TB data management system now, because in long runway, we really want to make sure that like these are sustainable efforts, number one. And second, it speaks to the other elements. Why I'm saying so, I think, and that also leads to my eighth point, that we really want to be aware that like what are the still social determinants of TB. TB social determinants are really classic, like undernutrition was one of the major things. But then there are others, like diabetes mellitus. It's still there. Like India, what I can speak about is like when we say 3 million around TB cases, but for diabetes, we are also 64 million diabetes cases, and they are all at high risk of developing TB. So if we don't have the data intelligence of the diabetic patient, we really can't find the TB cases. So we really want to make sure that like in our longitudinal database, whether we capture these data elements on the other elements, either from the maternal and child health division with the other health elements. So I think the investment should also be on the HMIS, but on the broader side rather than a digital. Ninth point, I think, on the research, and I think Dr. Sachdeva also alluded to that, or Dr. Sahu also alluded to that. Believe me, I started my career in 2004, and typical doctor, like we think just that, no, we will diagnose and treat, and this will be over. TB is not that case. Diagnosis and treatment alone is not getting us, and Bacilla is really smart. And you have seen that like how it has evolved on the, drug resistant pattern, interacts with the other diseases so fast. And this is going to continue. AMR is again a big piece here because the antimicrobial use, rational use is still a thing where I see that like countries are struggling to have the control measures. And that's why if you take away, eyes from the bacilli, that like, okay, enough research has been done, enough tools right now are available. Let's forget about some research. We are actually going to do a mistake. So continuous investment in TB research. I think global figures, what we have seen here on the overall broader research clinical trial. But I will urge that like most of the time, we also concomitantly need our operation research. It's not only about the clinical trial, but what are the best way of implementing the same tool in a different setting? Because no each geography is common. At national level protocol, broader guidance can't be implemented in that same manner and fashion and never will be adequate. You will require a local level innovation to do the implementation of similar approach, or we have to really see the community-based approach. I think CLM also one of the things. So constant effort and support will be required to do that. And I see that no, most of the time, like TB community, TB, like if we go to any conferences, like we find many similar places, same faces, right? This is the time where we will really want to encourage, and maybe at your level also, you interdisciplinary team. I'm saying so because we will require interdisciplinary team, and we have seen in COVID, once the interdisciplinary team comes into play, miraculous kind of stuff emerge. And the same I would urge. And also the emerging tech AI that can really help. So maybe last point on the things where I see this as ending as the partnership. And as Dr. Satya also mentioned, this is the time. Someone was actually asking me, how are you doing? And yeah, I'm working on this. Then I slowly realized that this is the best time if you are working in TB. This is the best time. Like the unprecedented political commitment is there. There is a actual enthusiasm of ending TB is there. Also, there are adequate tools available, and there are some really exciting tools which we are expecting to be added to that. So that is that I think that like the partnerships at all level will be of crucial, and that will also really help to keep this momentum of TB elimination. I'm really confident that like with all our kind of efforts together, we can end TB by 2030. Thank you so much.
Thank you very much, Dr. Shah, especially for focusing on the importance of local action, primary care, and data on social determinants of tuberculosis, other than data on TB also, and also interdisciplinary connect. There have been cases, in fact, I have interviewed TB patients who went to doctors, from one doctor to another. All tests were done. There were TB symptoms, but a TB test was not offered. And so it was not that the patient was not seeking help. And the patient says in his interview that, well, I went to the doctor and I did whatever the doctor asked me to do. I was tested for typhoid, so for so many other diseases, but not TB. Unless somebody asked him to do so. And the person who asked him was working, and Dr. Amar, I'm talking of the Humana project, which is happening in Delhi. And they said that why don't they got him tested for TB and he tested positive. So that interdisciplinary action is important. And now I would ask Dr. Bianca, and she has to make some announcements, I think. Is she here in the room? Yes.
Good morning, everybody. I'm Bianca from Mobile Diagnostics. I just would like to give you a few announcements with regard to logistics and some of the arrangements. First of all, I hope that you're all well settled in your room and everything is okay. If there is any issues that you're having, please consult my colleague Winnie and myself at the back. We will try to make things easy flowing for everybody. This afternoon, we will be going for a visit to a point of care where the TrueNAT is being made. the manufacturing unit. So for that, I would like to request the ones who are visiting the factory to kindly give your names to Trajan. Trajan, can you please stand up, please? Please give the red gentleman, the gentleman in red, who's going to help me with your names. And also I need your lab coat sizes so we can get those ready. So your names and the size that for the lab coats that we have to. So please meet with Trajan and he will give you this. For those of you we will have the bus available at 2 o'clock, between 2 to 2:30, which will take you to the site. For those of you who do not want to go to see the factory, please remain here because we will, drop you back to your hotel. The ones who are going back to the hotel and not going for the visit, your dinner will be at the hotel where you're staying. But for the ones who are going for the visit, your dinner will be here in this place. Today's lunch is all here at 1 o'clock, and it's in 2 rooms next to the reception. You have on the right and on the left. There are 2 rooms. They're the same. You can pick any. Another point is tomorrow morning, for the guests who are in another hotel, the bus will pick you up at 8:30 to bring you here. Okay. Before we go to a round of introduction, I just wanted to get everybody's attention to a signature campaign that was started. Maybe you'll speak later about it. We had, along with Shubha ma'am and Bobby and the journalist group and Asian Pacific Mayor Alliance, we had met in Goa initially to start this global call to find all TB, to stop TB. Most of you have endorsed it, but if you have not, please, there is a signature that you can put your names on there. There are a little bit of the ask that you can go through. And if you feel, yes, this is what we got to do, kindly sign the signature, put your signature on that, the campaign. And of course, I've also kept a whiteboard. Throughout the 3 days, we're going to have a lot of ideas that we're going through, we're going to be discussing. And sometimes we may not be having the opportunity to speak them out. There are some sticky notes on your table. You can just write your idea on there and you can stick on the whiteboard, or you can write on the whiteboard so that when we collate it at the end of the day, we have everybody's inputs included. Yes? And of course, as the day goes by, Shobha ma'am will be taking you through the agenda and how it's going to play. Just a few more things. Should we do a round of introduction? So what we're going to do is we're going to go through a round of introduction, but at the same time, there's also tea available. So what you can do is also bring your tea to your table. But I think we can start with a whole round of introduction of who you are, where you're from, and which sector you're coming from. Would that be okay? Yeah? All right. Yes, can we get the microphones, please? Okay, I begin with myself. I'm Dr. Darivianka Lalu, General Manager for Partnerships with MolBio from India. Can we get the microphones, please, to everybody? Microphones. Yeah.
Hello, good morning with everybody. My name is Dr. Miguel Garcia. I'm coming from Ecuador, South America. I'm working on a university over there, University of Las Americas, and we work on molecular epidemiology of tuberculosis and improving diagnostics tools for tuberculosis and other infectious diseases in collaboration with the Ministry of Public Health in Ecuador and the National Institute of Health.
Hello, everyone. My name is Mario Latte. I'm a consultant of MolBio for Latin America.
Hello, everyone. My name is Tatiana Cáceres. I work at University Peruana Cayetano Heredia, and we work with MolBio in different projects through Fine Diagnostics.
Hello, everybody. My name is Henry Vela. I am from Peru, and Molbayo consultant for Latin America. Hello, everybody.
Hello, everyone. My name is Darren, and I'm distributors of mobile, and I come from Myanmar. Thank you.
Good morning, everybody. I'm Dr. Ashwini Khanna. I'm a pulmonologist by training, and I've been a former state TB officer for Delhi and running the program, and been a part of the national program also at the national level as for different projects. Thank you so much.
Good morning. I'm Dr. K.K. Chopra, pulmonologist by education, and I am a clinician. I worked as director of New Delhi TB Center, which is one of the premier institute in India in TB control. I'm also associated with TB Association of India, which is publishing its journal, Indian Journal of Tuberculosis, and conducting national conference network. Thank you.
Good morning. I'm Dr. Kuldeep Sachdeva. Currently, I'm the President and Chief Medical Officer Strategy for Malbio Diagnostics. I've been a former NTP manager at the Government of India for TB, former manager for HIV/AIDS, again at Government of India. I've also led the India Country Coordination Mechanism for Global Fund. I was leading that. I led the COVID response through a World Bank project, the first COVID response. And I'm also a former regional director of the Union Southeast Asia. I have special interests in TB, HIV, antimicrobial resistance, rational use of drugs, and look forward to interacting with you in this meeting. Thank you.
Hello, everyone. I'm Kalpana, a health journalist from Kathmandu, Nepal. Thank you.
Good morning, everyone. As I said, my name is Turit Chakraborty. I'm from West Bengal. I'm the board member of TB People India. Thank you.
Good morning, everyone. My name is Tadele. I came from Ministry of Health, Ethiopia. I'm working as a national TB, leprosy, and other lung disease. I'm senior TB supply chain advisor.
Good morning, everyone. I'm Adisalam from Ethiopia, a commercial partner of Molbayo Group. Thank you.
Good morning, everyone. My name is Getachew Aga. I'm working at Ministry of Health of Ethiopia as Senior TB Laboratory Advisor at National TB and Other Lung Disease Control Program. Thank you.
Okay, good morning, everyone. I am Shauki Moga. I came from Ethiopia, working and currently managing the National TB Reference Laboratory. Thank you.
Hello, everyone. My name is Huy Huyen. From Vietnam, I'm Associate Program Director for France for International Tuberculosis Relief as the German NGO working in TB. Nice to meet all of you here in beautiful Goa, and thank you for having me here. Thank you.
Good morning. I'm Dr. Tanaimao from TB Program Manager from the American Association. We are collaborating with the NTB for the especially for the private sector engagement and then accelerating case finding. Thank you.
Good morning, everyone. I'm also from Ethiopia. I'm a senior infectious disease advisor for USAID Ethiopia. Thank you.
Good morning, everyone. I'm Dr. Patrice Mirumbe from Tanzania, DMPB. We are the distributor for Molbayo. Thank you.
Morning, everyone. My name is Samuel Mulungu from Tanzania, passionate about TB diagnostics. I'm working with DMPB. Thank you.
Good morning. As we say in Tanzania, Swahili, habari ya asubuhi. My name is Dr. David Sando. I am the Chief Executive Officer for a local NGO that supports the Ministry of Health on scaling up TB molecular test. We are also Global Fund principal recipient, supporting the TrueNat also scale up, and it's a pleasure to be here. Thank you.
Good morning, everyone. I'm Dr. Maiga from DMPB Medical Group as a distributor from Tanzania.
Good morning, everybody. My name is Benson Mopaja. I'm from Tanzania, where there is a highest mountain in Africa. There is a gorgeous safaris, and there is a beautiful island in Africa. I'm distributor for mobile for my group, DMPB Medical Group. And I also live in Tanzania and USA. Thank you, everybody.
Good morning, everybody. My name is Dr. Henry Nagai. I work at JSI in Ghana as the Chief of Party of the PEPFAR program and also the immunization team lead. Thank you.
Hello, everyone. My name is Tarok Taza. I come from Zimbabwe. I'm the National Coordinator for TB People Zimbabwe. And also I sit in the country coordinating committee, Global Fund, representing communities in my country. At the regional level, Southern Africa, I also represent KVP in the TB mining initiative. And I'm the board member of SOFD Partnership of the newly formed KVP delegation for SOFD Partnership. I'm happy to be here, and as communities, just to put us at the center, then everything will happen. Thank you.
Hello, good morning, everyone. I'm Jomer Villanueva. I'm from Gets Healthcare, and we represent MolBio in their commercialization in the Philippines.
Good morning, everybody. I'm Ian Grist. I'm also with Gets Healthcare in the Philippines and proud partner of MolBio. Great to meet everybody.
Good morning, everybody. I am Mary Bibu Sadekova. I am head of National Reference Laboratory, TB Center from Kyrgyz Republic.
Good morning. My name Kadyrov Abdullah. I am manager in the program of Kyrgyzstan.
Thank you. Good morning. My name is Refilwe Maji from South Africa, and I'm not here to debate about cricket with our colleagues from India, but talking about TB this time. And I'm a CEO of a local non-governmental organization working in South Africa on issues related to community screening and bringing services closer to the communities, and that includes tuberculosis. Thank you.
Good morning, everyone, and welcome to the great city, great place, Goa. I'm Mani Subramani, and I am based in the United Kingdom, and I handle the business for MolBio in Europe and CIS countries.
Good morning, everyone. Maayong aga sa aton tanan. I am Dr. Samantha Tinsay, Municipal Health Officer of Bantayan, Cebu, Philippines, the sole implementer of the 3 tools, AI, ultra-portable X-ray, and the TrueNat in our island municipality. So you'll see our talk tomorrow. Thank you for welcoming us in India.
Good morning, everyone. Thank you for inviting us to Goa. I am Dr. Lelaine Mortera, previously from FHI 360, who implemented INTP under the TB Innovations Project funded by USAID. I'm a pulmonologist by profession, currently the assembly head of the Asia Pacific TB. Good morning, everyone.
Good morning, everyone. My name is Agnes from Zambia. I'm the distributor for mobile from Straton Life Sciences. Thank you.
Good morning, everyone. My name is Mundia. I'm also from Zambia. I'm representing the National TB Reference Laboratory and, of course, Ministry of Health, Zambia. Thank you.
Good morning, everyone. My name is Romre Parfait. I come from Burkina Faso. I'm an engineer. I work for Ria Express.
Hello, good morning, everyone. I am Dr. Timothy. My pen name is Dr. I am the former chief editor of Health Digest Channel from Myanmar. Thank you.
Good morning, everyone. I am Dr. Mahfuz Rahman Sarkar, Line Director, TB Leprosy, AIDS and STD Control Program, Director General of Bangladesh. I come from Bangladesh.
So good morning, everyone. My name is Michael Menoge from Nigeria, control rep for Mobile in some parts of Africa. Thank you.
Hi, everyone. This is Dr. Rupali Shishir-Banu. I am National Program Coordinator working for National TB Control Program, Bangladesh. Thank you.
Good morning, everyone. This is Dr. Shaila Islam. I am working in BRAC. BRAC is a community-based non-government organization in Bangladesh and one of the large implementing organization working jointly with National TB Control Program in Bangladesh. Thank you very much.
Hello, everyone. Good morning and Assalamu alaikum. I'm Tasnim Maliha, working as a microbiologist in National Tuberculosis Control Program, Bangladesh. And thank you, Malbay, for having us.
Hello, this is Nurul Islam Hasib. I'm a journalist from Bangladesh. I work with Dhaka Tribune newspaper.
Good morning, everybody. I am Senu from Supranational Reference Lab of Benin. I represent here the National TB Program of Benin, Director of Super National TB Program, Diswa Folabi. Thank you, everybody.
Morning, everyone. Bonjour à tous. My name is Songa Jack. Mon nom est Jacques Songa. I'm director of Rea Express Company located in Burkina Faso. Je suis manager général de Rea Express au Burkina Faso and I'm mall bio distributor. Je vais rajouter, parce que c'est exclusivement anglais, on aurait voulu depuis la session passée. In the last session, we asked to get small translation machine for us because we come from West Africa and we speak exclusively French. And to help us to understand, all you understand, it's very, very necessary for us. Je vous remercie.
Good morning, everybody. Thank you, Mr. I'm French speaking, so I will try to introduce myself in English. I won't be long. I'm Dr. Guy. I come from Côte d'Ivoire. I work for the National TB Program, and I'm responsible of the lab network. I've been invited here by Rea Express of Burkina Faso, and I'm very happy to be here with all. Thank you.
Good morning. I am Gérard Kadanga, come from Togo. I'm working in National Tuberculosis Reference Lab. Thank you.
Good morning. I'm Abdul Nur Nyombi. I'm a laboratory scientist working with National TB Reference Laboratory in Uganda.
Good morning, everyone. My name is Bashir Ahmed Lumala. I come from Uganda, and I work with BioHealth. We are the partners of MolBio in Uganda. Thank you.
Thank you. My name is Moses Jorova from the National TB Reference Laboratory, Uganda. Nice to see you, colleagues, and thank you for arranging MolBio.
Bonjour tout le monde. Je suis le professeur Michel Cassois de la RDC, directeur du programme national. Je pense qu'une de mes spécificités, c'est que j'ai été pendant plus de 5 ans aussi chef du labo national de référence. So, good morning all. me, I can talk in French and in English. I'm the Professor Michel Kassoa Kayomo, NTP manager from DRC. But also, I was talking to my French colleague. That's one of my specificity. That I was a National Reference Lab head of office for 5 years, I guess. So I'm very understanding very well all those questions of scaling up a rapid molecular test. I'm also professor at the University of Kinshasa and the School of Public Health Kinshasa. Thank you.
Hello everyone, good morning. I'm Suresh coming from DRC Kinshasa, HJ Pharma. We represent Molbio.
Bonjour tout le monde, je suis Apollinaire Kilundu, directeur adjoint du programme national de lutte contre le VIH. Morning everybody, I'm Apollinaire Kilundu from DRC. I'm a deputy director in HIV program. Thank you.
Good morning, everyone. I'm Charit from Sri Lanka. We are the channel partners for Molbio Sri Lanka.
Good morning, everyone. I'm Dr. Nali Rajapaksha. I'm a consultant community physician. So in other words, I'm a public health specialist from National TB Control from Sri Lanka. So at the national program, I'm doing the lab coordination, and also I'm technically leading a preventive therapy program in Sri Lanka, and also drug-resistant TB, and also research and training. And actually, Sri Lanka is an island in the Indian Ocean. So being separated from the mainland, I think, has its own disadvantages. So we usually don't get selected or get represented in forums like this. So I want to thank Molbio. Thank you very much for giving us this opportunity to come to this meeting and get exposed to experiences from other countries. Thank you very much.
Good morning, everyone. I'm Dr. Pramita Shantilata, Director, National Program for Tuberculosis Control and Test Diseases in Sri Lanka. Thank you very much, Molbio, for inviting us.
Bonjour tout le monde, je suis Dr Mariette. Je travaille au laboratoire national de référence des tuberculoses. Je suis responsable de biologie moléculaire et je suis le point focal TruNAT dans le projet NTP. I'm Dr. Mariette. I working at National Laboratory. I am responsible biologique moléculaire.
G'day, I'm Adam Dodkins from Cat Laboratory Medical, along with my colleague, Ms. Shireen Singh. We're from South Africa, and we're a commercial partner for Molbio for Lesotho, Swaziland, and South Africa. Thank you.
Morning, everyone. My name is Tapiom Gaza, Molbio partner Zimbabwe, and devoted clinical laboratory scientist. Thank you.
Good morning. My name is Abraham Andom. I'm from Eritrea, Molbio distributor in Eritrea. Thank you.
Good morning, everyone. My name is Daniel. I'm the Molbio lead consultant for Africa. Thank you.
Good morning, everyone. My English is very poor. French is my first language, but I can try to be present in English. My name is Dr. Tolo Daniel. I'm coming from Cameroon in Central Africa. I'm working to National Tuberculosis Control Program of Cameroon. I am a aide or chief of pharmacy and tuberculosis and the laboratory section in this program. It is great for me to be here. Thank you, everyone.
Bonjour à tous. Je suis Dr. Daouda depuis le Cameroun. I'm Dr. Daouda from the Cameroon. I'm working in Department of Pharmacy and Laboratories. I'm Chief of Supply Divisions of Pharmaceuticals and Lab Products. Thank you. I'm happy to be with you.
Hi, this is Seema Ansari. I am managing the Corporate Social Responsibility and Philanthropic Initiative of MolBio.
Good morning. My name is Kwima Kumwenda. I'm the Managing Director, Tofu Diagnostics, Malawi and Zambia Limited, distributor for mobile in Malawi. Thank you.
Good morning, all. My name is Chifundo Hiwa Kamlon. I am from Malawi, the warm heart of Africa. I work in the Ministry of Health as Assistant Deputy Director in the Department of Diagnostics. Thank you. And I'm very happy to be here.
Good morning, everybody. My name is Grace Kahenya. I can just start by saying I'm the mother of Tronat. I worked with, which has closed, USAID IDDS project. If you all remember, I think all the countries here, we've been supporting the INTP in 9 countries. We've been working in collaboration with the Stop TB Partnership. We've developed the training packages and did the implementation in those 9 INTP countries. So at the moment, I'm now in a new position. I'm working, I'm a consultant again with the USAID, that is the Global Health Technical Assistant Mission Support, just for a short while. So we are looking at the INTP countries, which are 9, how they've been implementing the TrueNANS, as well as scaling up, because other countries are now scaling up. So we are supporting them to make sure that they do it according to the guidelines which we have developed. So I'm happy to be here. I want to thank Mobile for supporting me, that I'm here. And I'm happy to see all the countries we've been supporting here. So at least we have a lot of discussions. We see how the implementation, what are the challenges and what are their experience and what are lessons learned, especially for the new countries coming up. So you learn more from them. So that's me, the mother of TrueNAT. Thank you very much.
Good morning. My name is Catherine Mrombedzi from the TB People of Zimbabwe. I'm the Vice Chairperson of the Health Communicators Forum of Zimbabwe. The Health Communicators Forum is a grouping, a network of people, journalists in our diverse portfolios. We came to be in 2020 during COVID. We were restricted in movement, and through the IVEC, we formed the Health Communicators Forum. And from there, we have been growing. We now have partners in Malawi, Zambia, Uganda, most of Southern Africa and East Africa. So I'm very privileged to be here. Thank you to MolBio. I'll be meeting you alongside these 3 days. Your story will help in ending TB. You are a voice to ending TB. So let's meet alongside this conference. We go outside, we chat, we write about what you are doing to end TB in your country. It's a global effort, and I'm very pleased to meet you all, the great experts in public health. Thank you.
Good morning, everybody. My name is Zarina Gelu. I'm a health writer.
I'm also the lead coordinator for MESICA, which is the Media Science Cafes. The cafes brings researchers and doctors such as yourselves together with journalists, where we have informal discussions on health issues, TB included. I'm from Zambia, the home of the 7th national wonder of the world, Victoria Falls. We've claimed it from Zimbabwe. And very, very happy to be here. Yes, they have. They did. No, they won't send me home. I have Trunat, mother of Trunat here. So I have one ask from participants here. As I said, journalists, if you could be simple in your language. I hear a lot of acronyms and shortcuts being used. For us to follow the conversation, please simplify your language, explain the acronyms so that we can report you accurately and in context, which is one of the main complaints that researchers have with journalists. We'll talk more about that later. And yes, I will be pulling people aside to have discussions. This is a very important conference, and it would be a pity if I let you go without at least interrogating you for a bit. Thank you very much.
Good morning, everyone. My name is Thái Nguyễn. I'm from Techmark, a company who are distributor mobile in Vietnam. We are very proud to be one of sponsor distributor in Asia. Besides a distributor mobile, we are partner of National Tuberculosis Program in Vietnam. So what we hope that in the near future, a member of the National Tuberculosis Program come here and have some story with you. Thank you.
Good morning, everyone. Welcome to Goa. I'm Eunice, one of the business consultant of Molbio handling the ASEAN market. Thank you.
Good morning, everyone. My name is Yvonne Kanjejo from Kenya, Molbio consultant for Team Africa. Thank you and welcome to Goa.
Good morning, everyone. My name is Isa Saidu. I am one of the consultants for Africa, Molbio.
Good morning. I'm Sriram Natarajan. I'm the Director and CEO of Molbio Diagnostics. Very happy to welcome all of you to Goa. I really wish this meeting all success, all big countries here, and I'm sure you'll have great deliberations and we'll have a positive outcome from this meeting. And in the meanwhile, please enjoy Goa. It's a beautiful state, and please enjoy the hospitality. Thank you very much.
Good morning, all. My name is Shiva Sriram. I head business development at Molbio. Welcome to Goa and looking forward to interact with all of you. Thank you.
Namaste. Good morning, everyone, and welcome to India. See a lot of old colleagues out there. I've been largely a part of India's fight against TB before I moved into the corporate sector. I'm currently with Molbio. I head product management, marketing, and communications for them. And I welcome once again all of you here. Have a great time.
Thank you. Have we missed out anybody? Oh, sorry. I couldn't find you.
Good morning, one and all. My name is Sumit, part of the Molbio team. I must take a few names. Prof. Joloba, Prof. Michelle, whom we met in their respective lands, Ian from the Philippines. All of you have traveled long distances. So welcome. Our team from Bangladesh, very close to my heart. And as Mr. Shriram said, enjoy the hospitality. We look forward to great deliberations and, of course, the media partners, Arena included. You have your pick, choose whom you want to interact with, and don't let them go. Thank you very much.
Oh, thank you. Good morning, everyone. My name is Trajan Mokalazi. I'm a MolBio consultant on the Africa team. It's great to meet you all.
Thank you, everybody. I think we have Bobby.
Hello, everyone. I'm Bobby Tamakan from CNS, and thanks a lot for coming over. Sorry. Okay, all right. Yeah, so thanks a lot for joining forces, rather. You know, it's really great to be here in the same room with the same mission, and really hope and re-echo what Bianca had said. Please do put up your sign, your endorsement, your support to find all TB and treat all of them. And of course, we need to stop the spread of infection if we are to end TB in people-centered ways. Thanks a lot for joining here, and special thanks, of course, to MolBio for all the support and help. Thanks. And of course, to TB people, India and Zimbabwe for joining hands, and all the journalists who are here. Thanks.
I think. Excuse me, sir.
Yeah, I am Dr. Manish Gaonekar, State TB Officer, Goa. Welcome to Goa.
Everybody, there is tea available at the back. And if you want, grab your tea and then we can, can come back so we can begin with the next session. Oh,
Yes.
I'll hand it over to you, ma'am.
We begin the next session. So tea is there, but the next session is there also. So you'll have to divide your attention between the two. I would now invite Dr. Sachdeva to please chair the next session on India's National TB Elimination Program implementation over the years. Dr. Sachdeva. There is a chair for you on the dais, and let us have a mic.
Okay, announce kar do. Hello, friends. Probably we'll take a 5 minutes break. Please grab a cup of coffee or tea. It's right there in behind. And then please come back to your table so that we can begin the session. Thank you. Hello, everyone. Hello. 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 Please grab your coffee and come back to your tables. Please, friends, grab your coffee, tea, come back to your tables. We need to begin the session. Hello.
Can we ring a bell, please? Or clap our hands for people to come back, please? Clap your hands if you are happy with the proceedings so far, and please come back to your seats. I hope my voice is reaching across the room. Please, may I have your attention? Please grab your cup of coffee and sit on your chairs or places, please.
Are the guests who are outside, please, could you come back in? Our guests who are outside the room, please, could you come back?
I'm sure we'll have more time to interact during lunchtime and later. And once again, I invite Dr. Sachdeva to please chair the next session. Dr. Sachdeva.
I need help of few journalists to settle the crowd.
Okay.
Hello. भाई हमने अपने टीम को
Can we
volunteers
all
की-
get back to our seats, please?
We need volunteers to settle the crowd. Good. Can I have your attention? Please settle down. Bobby, let's settle down. Okay, can I have your attention now? Good. I think okay, the next session will talk of a few success stories. So you heard two speakers today. One is Dr. Suvanand Sahu and then Amar Shah. So they basically laid down the context of ending TB and how can we accelerate our actions and find all TB to stop TB. So within that context, now we'll have few examples because we took the liberty of being the host country to start with India. So we'll have examples from Delhi, Goa, and then we'll also have examples from other countries. And then we'll discuss how can we replicate those success stories in each and other country. What is the take-home message from there? So listen carefully what the presenters are trying to showcase their success stories, ask questions, clarify how do we actually implement it on ground, and then let's reach, because in the end, we are trying to make a consensus statement or a recommendation to a global body and then take it on from there. So I'll introduce my
first speaker. He did introduce himself earlier. Dr. K.K. Chopra, Kamal Kishore Chopra, is former director of an intermediate reference laboratory in New Delhi, India. He's also the Secretary General of TB Association of India, the largest association in India for TB, and which is in existence since 1930s. So it's a very renowned association, and they have more than 28 branches within the country in various provinces. He is a pulmonologist and has a rich experience and devoted his life in TB, both on the clinical side as well as on the laboratory side, as well as on the public health side and the policy making and other things. So I'll request Dr. K.K. Chopra to come on the dais and present his.
Thank you, sir, for a nice introduction. First of all, thanks to CNS team and Dr. Sachdeva for inviting us, for sharing our experience. I'll be sharing my experience about active case finding. That is the first topic of this panel discussion. This is about the active case finding which have been done by New Delhi TB Center, my institute. In most of the studies, I was the principal investigator. So I'll be sharing my experience. During my presentation, you can stop me if you have got any question or if you want any clarification, I'll be happy to tell. As Dr. Sachdeva said, before ending TB, we require to find the cases. Now, there are many equipments to find the cases. By passive case finding, which we have been doing for many years, we are not able to end TB anyway. Active case finding is must, because we are missing many cases, because from community, many times persons who are having symptoms suggestive of TB, either they are not coming for healthcare, or in India, what we observed in our awareness session, even if community persons, they have got some symptoms, they say it might be because of smoking, might be because of air pollution, not coming for target. So if we say, why you are not going for taking healthcare, they say there are big lines in government hospitals. We cannot afford private sector, so they do not go. When our workers go and tell them that TB services are free for you for diagnosis and treatment. Now what they say, that fellow told me that services are free, but where they are situated, we never know. So in all sessions, whenever I go to community, I make sure that if any health worker says that facilities are free, they should tell where it is located. And most of our dot center, like in Delhi, we say we have got 2,200 diagnostic centers. So though there is no rush, they can go, no charges for all diagnostic treatment activities. So by definition, what is active case finding? So it is a systemic identification of people with presumptive active TB in a predetermined group. So we select a group and then do active case finding using tests. We may need radiological examination, may need a molecular test to examine, and examination or other procedure that can apply rapidly. It should be rapid, test should be sensitive, and they should be point of care tests. They should be in the field, like either handheld X-ray machine, which we have used recently, molecular test, which is point of care test, can be done in the field. Among those diagnosed, that is the second point. There's no point of doing an active case finding in an area. After detection, we should align them with the treatment facilities. Like in Delhi, I say there are 500 treatment centers now. So any patient who is diagnosed, that patient should be linked to some treatment center. That is our moral duty to ensure that treatment is started. We have got NICSHA, that is online portal to notify and register our patient. So there should be NICSHA entry also. This is a public health action which should be done after diagnosing any patient in community. I'll show how we ensure in our operational research studies. So active case finding, three most components. So active case finding can be in general community, can be in high vulnerable setting. So it depends on what is your target. Like in India being high burden country, it is almost impossible to conduct any survey or active case finding in general community. So it is better to select some target group like for doing active case finding, which are vulnerable, where incidence of disease is more as compared to general population. Household contacts. There are many times more chances of incidence among household contacts, especially of smear positive or who has a microbiology confirmed. Second group is people living with HIV. So any person who is coming to ART center where we get where the patient gets antiretroviral treatment, and other are ICTC center where there are diagnosis for testing for HIV is done after giving full counseling. So these are the center where patients, people living with, not patients, they are people living with HIV, they are coming. And it is said that 70% of people living with HIV, they develop tuberculosis during their lifetime at any time. And 50% of them, this is a study finding, they die because of tuberculosis or some complication of tuberculosis. So that is another high risk factor. Third is the current and former work of workplaces like silicosis industry and other occupational hazard where people are working, which make them most vulnerable to disease. Silicosis is one of the such example. So active case finding is screening. In addition, there should be screening of selected groups which are thought to be high risk. One group like patients suffering from any kidney disease or going for dialysis, perhaps patients going for organ transplantation, persons taking steroids, because all of these causes decreased immunity. And if a person is infected, they are going to develop disease. So there are more chances of disease. So we should take up these patients also for active case finding. There are many studies done in different countries that I'm showing just example that how ACF is active. I found one study from the Uganda. They studied in among chronic coughers in slum settings. So one is slum setting. In slum, there is overcrowding. There's no cross ventilation. They're usually poor persons, malnutrition. These are all risk factors of tuberculosis. Then they were chronic cougher also. So if anybody has got cough, there are 10 to 20% chances that they may turn out to be tuberculosis. And what the findings suggested, active case finding, it supplemented the dots, patients coming for directly observed treatment that increased. Second finding important was that shortened the duration of infectiousness. Dr. Sachdeva highlighted that there is a need for early diagnosis. There is no point of diagnosing a person when he's infected or having symptoms for more than 2 months. That patient has already infected many persons. So because of active case finding, we are actively finding them. It decreases the duration of infectiousness. So transmission changes also stop. Another study I have found that of southern Ethiopia, they did it village outreach setting. In some villages, they conducted these studies. What they found that it is effective in improving the speed. Maybe a person with symptom might come to health center, but very late. By doing active case finding, they speed it. They made early diagnosis, same as in the previous study. So should we conduct studies? So these studies and 5 examples of active case finding study I'll show you. That active case finding is effectively in TB control program in any country, any setting. So these are some of the vulnerable groups, like in the juvenile centers people are living. These are the night shelters where persons who cannot afford housing, or if they are homeless, they stay there. These are another example of night shelter. So they are vulnerable groups. In our national TB program, they have identified the vulnerable group where active case finding should be done based on the urban area, rural area, tribal area. So because Delhi is where I am working, that is an urban area. So we focus on the urban area, and we conducted these type of studies in slums. In prison inmates, Delhi has got one Tihar jail. That is, I think, biggest jail in prison in Asia. Old age homes, night shelters. There are around 200 night shelters where homeless people stay at night. Then there are homes for destitute also. Children who are street workers doing any crime, they are brought to these homes where we conduct actively case finding also. So I'll show that active case finding. First initiative, mobile screening project. For active case finding, we are not bringing the symptomatic sutures clinic or any TB center. We are going in the field, with X-ray machine, which is handheld, taken in a van, and now that we are taking corporate support from many companies like Medanta Hospital supporting my initiative. They are giving us van, then they are giving a handheld machine, and now they have come out with a mobile bike. So in bike, ultra light X-ray machine, which is handheld, can be taken by one person to the field in areas where there are no roads. So in that, we have conducted this study for last 3 years. We are conducting in different phases. We are screening by symptomatic screening. Then in homeless people, we are doing radiological examination of all the persons, because in symptomatic screening, may miss many patients. So all homeless people, they are screened by radiological examination. At the same time, that the X-ray is given by WhatsApp group to one of the group of doctors or pulmonologists who does study of that, and immediately results is sent to the team which is working in the field. They have got facility of sputum collection and doing molecular test in the van itself. So the moment X-ray reaches our one of the pulmonologists, if he reports it is suggestive of tuberculosis, immediately sample is taken and molecular test is done. Daily TB Association is giving treatment to these persons. Patients who are diagnosed, their team are also there. We are conducting this type of activity 3 days a week. There are 2 vans. One is doing X-ray, sending X-ray to pulmonologists, getting reports same time. Molecular test is done in the field, and the same day, first dose is given to the person. So we say it is a same day treatment, but we have found up to 70% cases we could put patient on treatment on the same day. Otherwise, they are homeless people. If we wait for second day, we might lose many patients. So this results I have shown in the 2 phases which are there, and final results are 5 to 10% was the TB cases found among screen. These are among the homeless people. Average comes out to be 6%. Range varies from 5 to 10%. Among homeless people, slum dwellers, this is the results which you have seen. And in most of cases detected, 70% cases were put on treatment on the same day. We were taking help of the mobile molecular test machine. Also, there are district TB centers. In every area, we are doing this activity. Even the facility of molecular test, we are getting from them also. And from the same center where the person is residing, person is put on treatment. If they are homeless and do not have any place to reside, there are 2 rehabilitation night shelters where such persons are admitted at least for 2 months till they become non-infectious. This is a study for 3 years, still continuing in different phases, depending upon the availability of resources, which are portable X-ray machine and 1 molecular test machine where test can be done in the field. Another study, this is a part of operational research we have conducted. This was among female sex workers. There is a red light area in Delhi where around 2,500 female sex workers are there. That is known as GB Road area. We did this study as a part of operational research with support from the state TB program. We took the help of DSEX. DSEX is a Delhi States Aid Control Society, because community reach of many NGOs attached with the DSEX, that is a States AIDS Control Society, is very good. So we took hold of one of the NGOs, took their workers. We met the managers of these brothels so that we could get entry. We appointed one of our coordinator who used to go in the evening time with permission of those managers to give health education to the inmates, telling about what are the symptoms, where are the facilities, collect 1 sputum sample during the awareness session if any one of them was having TB symptoms suggestive of TB. NGOs working in that was involved, that was working with D6. So what we did, we tried to, because they were not willing to come to the hospital, because in that area we could not get an X-ray machine at that time. The study was conducted around 5 years back. We took hold of the peers among the female sex workers who were previously working as female sex workers. Not now, they were working for the welfare of these female sex workers. One NGO member, one peer, we asked them to bring the symptomatics to New Delhi TB Center, which is only 1 kilometer away from that area, in auto. And we were giving 50 rupees incentive to the NGO member and 50 rupees incentive to the peer so that they bring them. Then came the problem of their confidentiality. So we made an operational framework where these NGO or peer workers will bring symptomatics. They need not to stay for registration in any queue. We have got a female medical social worker. She used to receive them, get their X-ray test done. Digital X-ray film was done at New Delhi TB Center. Within 10 minutes, doctor sees the X-ray results and patient, and one spot sample was taken. If X-ray was suggestive of tuberculosis, if they are detected to be case of tuberculosis, then the treatment was given in their brothel itself with the help of same peer and NGO worker from the chest clinic, area chest clinics. So what we did, this was a 3 months planned activity. There were 32 brothels, 96 rooms, 2,500 commercial sex workers were there. Unfortunately, in 3 months, we could not contact all of them because their manager didn't allow to contact all of them. But what we could find, so this methodology I have cleared, we could contact around 2,570. A number was more than 5,000. So number of persons screened, we could not screen everybody with symptomatic screening. That was 1,875. There were 57 symptomatics. So all of them were brought to TB center and we could detect 12 cases among them. That included one extrapulmonary tuberculosis. There was a lymph node sent to the adjoining hospital to Dr. Khanna, and they confirmed it is a extrapulmonary. All of them were put to treatment in the place where they were working. They need not to go to any center, and they get full treatment, and we ensure they get full treatment in their place. So all of them got treated, continued treatment for the full course. Although only 12 TB patients could be detected in this study, but operational work which we have made, operational framework, that is still continuing. Still every week, 1 or 2 persons from that area, they come directly to my medical social worker with their X-ray. Within 10 minutes, they come to me and we make diagnosis. And if many a time in a 2 month or one, we detect at least 1 TB case. So that operational framework is still working. That is the advantage of this study. What issues we identified, that there are large number of females in each room. There was overcrowding. Teams not being given permission to screen all females because of their work profile. Time flexibility, sometimes our coordinator had to go on Sunday or any odd time where they could make them free. There was selective screening because few of them were, they never allowed us to interact with them. So we can say why we could get less number of cases, because it was selective. We could not get to interact with all. Problem identification, what we can do, IC, that is awareness activities has to be increased in their area. Peer workers, they are very helpful. We should take handhold of them. And then only then we can diagnose much cases. This is another example I am giving of active case finding. Central TB Division at national level in 2017. They started a campaign that every 6 months, in the month of January, July, and December, we will conduct active case finding among general population. So one dot center was selected in each district. Population of that center was, the active case finding was done. But after that, it has become a continuous exercise throughout the year. So I compiled that result of 2 weeks activity. What we could find, there also we made teams. One NGO was involved, and worker was involved. DTO made made selection of the areas where there are likely to get more chances, like construction workers or slum area. They did door-to-door survey with the help of a format where symptoms of TB were written. In every house, they used to identify how many persons are living. Do they have got any symptoms? They used to do awareness and then ask about the symptomatic. If there were any symptomatic, one spot sample was collected at the spot. And the person was asked to come to the chest clinic to get X-ray chest done. This is also 2017. At that time, even that mobile or handheld X-ray machines were not available with us. So we asked the patient to report to the nearest chest clinic and get X-ray chest done. This was the methodology used. Incentivize. Here the incentive was given to the team. There was a team of 4 workers, one from NGO, one from our staff, one ASHA worker we were training, and one local area. So 500 rupees incentive was given to the team when they diagnosed one TB case. They not only diagnosed, they ensured starting of treatment, entry into the next year. By this activity, this is 2 weeks activity. Out of 2,817 cases screened, we could detect 242. So yield is maximum when we do selective screening rather than going to the whole community. In selective screening, almost 5 to 10% TB cases we detect. Then another important study, this was also done as an operational research, IV drug users. Person who use IV drugs. There are 2 spots in Delhi, Yamuna Bazaar and Connaught Place. There are a lot of ID users who are lying on the or living on the pavements. They use IV drugs. We try to find out. So one day what we did, the day 1 when our team went, they collected symptomatics, got X-ray chest done. Out of the 12 cases they screened on day 1, 6 were having tuberculosis, extensive tuberculosis. So such was the incident. On that we planned an operational research. We did this activity, same as for the female sex worker, conducting awareness, bringing them to NDTB center for getting X-ray chest done, giving 50 rupees incentive to the IV drug users who was brought to that center, and 50 rupees to the NGO worker who was bringing it. There is one NGO working in this area. They were giving them supplement drugs so that they do not use IV drugs. So we got hold of them. With their help, our coordinator identified symptomatics, brought to the center. We gave 50 rupees incentive so that they come, saw their X-ray chest, same day treatment was started even in this group also. This was heavy. There were many cases in this case. Sensitization was done. Area chest clinic was involved. So what we did, 196 symptomatics were identified. 2 were sputum positive. In 30, X-ray was positive. In 3, TrueNet was positive. And what ultimately we could find in this group, there were around 32 patients, 32, 2 and 3, 35 patients were detected. 24 we could put on treatment. Rest we could not follow up on the second day. We could not identify them. So this is a very high yield area where I think this activity should be done regularly. Now, this is a summary of the studies which I have done. And one study was in Tihar jail. It was very difficult to conduct this study in Tihar jail. Dr. Ashwini was state TB officer. It took us 3 years to get permission to conduct active case finding in prisons for taking permission from the jail administration. Because that is a very sensitive area. And then we asked them to take our X-ray machine to the jail. They didn't allow us. They said it takes around 8 hours to screen your mobile van before giving entry to that. So what we took advantage of the X-ray facility which was available in the jail itself. We tried to contact medical officers. We contacted their pharmacists, health workers who are working, doctors, and even jail superintendent also. There are 12 jails in. So there were 12 jails. One coordinator was there. He was moving from one jail to another, Then in jail, the other problem is the inmates. 90% of inmates they were not the criminals or who were in prison. They were under trials. And under trial can be released at any time. Only 10% are real prisoners. In Tihar jail, we studied them. There was a place for 12,000 inmates. When we conducted this study, there were around more than 80,000 inmates at that time. So exactly it was 18,963. Now then they say they didn't allow my coordinator to talk to every inmates. I myself went to the jail, interacted with them, but not possible for me to go every day. So my coordinator was there. They said at 5 o'clock in the evening or 8 a.m. in the morning, there is attendance of inmates. So they call that time at one place, take their attendance. At that time, my coordinator was going there, doing their awareness, giving them sputum cup. Then the problem came. The symptomatics, many times they didn't disclose their symptoms. They thought might be we will get some problem. Otherwise, those who were not asymptomatic, they tried that I have got a symptom, thinking that maybe if TB comes, I will get bail. So then we discussed with the jail authorities. They introduced us to, they say Panjas. There are some prisoners who are in the jail for many years. They become informal of the jail authorities. In every jail, they have identified, though they inform any other activities or any mischief done by the other inmates, they are known as Panjas in their language. We caught hold of them. He told us that for so many days, this person is coughing, this person is coughing. Then our coordinator motivated them and collected the samples. XHS was done by them with the help of the medical officers. They study the XHS and sometimes they send the films to me for final confirmation of TB cases. So what we could do, presumptive TB, we could count 2,817. And this was a 6 months activity where 242 TB cases were detected in this project. This was a situation when there were 12 medical officers in that jail. There was one ward. There was one isolation ward for TB cases. There was a dot center in TB cases, microscopy center in TB cases, HIV testing in TB cases. So these were the number of patients which we detected in addition to routine detection. So this was the active case finding, which was additional. Then we also made an operational framework. Our objective was to detect and make an operational framework, because under the trials, they are usually released in the evening time. Whenever they got orders from the court, they have to release on the same day. We tried to mark, red mark in the area from where the persons were being released. Ask the jail authorities if there is any red mark, hold them, get them connected to our health workers so that we can shift the patient for treatment where he's going. But we could not succeed. That operation work could not succeed because jail authorities says the moment they get release order, they have to release the inmates. So that was lapse at our level. But what we tried with the help of NICSHE, because every patient was entered in the NICSHE, taking their address, but we were not sure whether they are giving right address or wrong because they were inmates. That was the main difficulty. But we tried through NICSHE to transfer. Not sure how many have been transferred. But at one time where they were diagnosed 244 additional cases, in addition to the patients who are taking treatment from the jail dot center, we detected that case. So these were the few studies. So conclusion was time-to-time screening. Either it could be periodic. Second is it should be planned by the chest clinic so that which area is to be taken at one time. There is no, maybe in general community we did, but it is not so fruitable general community. If it is a vulnerable group, there are many vulnerable groups, they have to be done. Short surveys can be done. Second finding was local NGO. Any NGO working in that local area, that will be helpful. In my studies, local NGOs help me a lot because they have got a reach, they have got faith in their community, and we can catch hold of them. Then they help in tracing the persons if we could not trace them. So this was all from my side. If there is any comment or any clarification, I'll do it.
Thank you, Dr. Chopra, for you showed many success stories. It's not just one. So I'll try to summarize. Somebody said the journalists need in simple language. So in the morning, I said, what has changed between in last 5 to 10 years in TB? So what has changed is one. In most prevalence survey, we have seen that 50% of patients who have TB do not have symptoms. Hence the need for active case finding. So this has changed in TB. The definition has changed from case detection, which is patients will come to you when they are symptomatic. You will take their sample and detect, to case finding, which is active case finding, to screening for cases, which is go out in the community, screen them. Screen them with what? He showed screen them with X-rays, which are portable, ultra portable, handheld X-rays. So that is what has changed in TB world, is that now we are screening for cases, not detecting cases, not finding cases. We have gone to the extreme step where we screen for cases. Which population to screen? He has shown you a lot of populations to screen. But people generally say when you screen, you can, depending upon your resources, you can screen everybody. But it is, since it is resource intensive, so you have to decide how much of resources you have and what level of screening you can do. Whether you screen vulnerable population, which he has shown, and vulnerability can be defined as per your local context. He showed prisoners, female sex workers, typically a hidden population. You will never get them in your clinics unless you reach out to them, and you have to do diagnosis there in their settings only. Now the diagnostic also has to reach them. So if you have to reach hidden population, you have to reach there, your healthcare worker has to reach, your diagnostics have to reach, your screening technologies have to reach there. So that's one paradigm which has changed. And what is the policy implication of all this done? The national program adopted as a policy the principle of active case finding. And India, almost 30 billion population is 1/4 of the total population is screened every year actively in one form or the other. So I'm not saying which form. They have different models. Each state, each STO Goa will also give you one model. Dr. Ashwani will also show you some other success stories, and many other countries will show. So every country can adopt a model on their own. The third thing is he talked a lot about incentives, profits. So we'll also show you how can you, at some appropriate time, how do you raise resources which are not typically from ministries of health. So you can raise extra budgetary resources from donor organization. Amar Shah is here, and I saw many countries are implementing USAID's ID supported projects. Also resources from for-profit companies. I also alluded what has changed is partnerships. So a lot of examples of partnership he has shown, involvement of civil society, community engagement, etc., which has resulted in this change. So if we have to actually reach out to all, get more cases, there is no alternative but to what Sahu called a search for cases. Don't detect cases, no, search for cases. So that's the message here. Open to questions and clarifications from Dr. Chopra.
I would just ask Dr. Chopra to give the full form of, you spoke of ASHA workers, and there are many in the room who would not know who are ASHA workers. So
in India, there is a concept of reaching to the community with some health workers, which are not actually paid by the government. They are based on the incentives. Like these female workers they choose. We say them ASHA workers. They are working both in rural and urban area. They are given a target of around 1,000 or 1,500 houses. There they do this healthcare facility. What they do, they visit their homes. They have got their records. Main activity of them is the antenatal checkup. They ensured institutional delivery because maternal mortality rate was very high in India, which has come down. So they give antenatal care at the home. Then they ensure vaccination, tetanus vaccination during the pregnancy in antenatal period. Then they take these persons or females for ultrasound examination in government facility, free of cost. Then their institutional delivery. They don't charge anything. Even the female who delivers, she gets incentive. Newborn child gets, if that is a female, they get incentive for the education, and ASHA worker also get their incentive. So these ASHA workers are helping the government in implementation of many symptoms, because if there is a initiative in a government to start measles vaccination, it started in Delhi state, ASHA worker helped us. When TB leprosy elimination was to be confirmed in that survey, ASHA workers helped it. Now we are taking help of those workers. We give them a simple performer, 4 or 5 questions, tell them whenever they are visit for antenatal visit to their covered area, they ask for 4 symptoms also. If anybody is having symptoms, suggestive tuberculosis, sent to the local dot center. Another incentive which we highlight them, if any case is detected with their help, we make them dot provider. Dot provider is community dot provider. So many times patient cannot come to the health facility to take treatment. So in community person, anybody who is accessible to the patient and acceptable, and who can keep mark our cards, we make them dot providers. We give drugs from the system for 15 days or fortnight. Patient takes drugs from that community worker, completes the treatment. And at the end of treatment, that community worker or our ASHA worker, they get the incentive. So ASHA workers get incentive if they detect any symptomatic or get sputum examination, then we incentivize them. If any patient is diagnosed in their area as tuberculosis with their help, we ask them to become community dot provider and get treatment also. So these workers are working throughout India, both in rural and urban areas.
So let me expand on this a bit. Again, this is a success story from India. Maybe many other countries will have. So ASHA is a Hindi word. Translated into English, it means hope. The acronym expanded as Accredited Social Health Activist. So it's an accredited social health activist. So who can become an ASHA worker? Typically, we have villages in our country, which is more than 600,000 villages. Each village has a population of roughly 1,000 or 200 households. So they select one female, and typically not the daughter, but the daughter-in-law, because she will stay in that village. Daughters get married and move to another village. So there is a connect with the community. So that is the concept they have used. So select a daughter-in-law from that village as a local key influencer to work with the community. She is not paid any salary. It's only purely on incentives. Whatever work she does, she gets incentivized by the government. So this constituency of these ASHA workers have been created in our country, and it's a very strong constituency of about 1.5 million ASHA workers in the country. And it's working very well. I mean, they work in that local setup.
Thanks, Dr. Chopra. You are the very impressive presentation. And we have also learned you are the lot of the experience about the active case finding here. In our country context, we are also conducting the positive case findings from the facility basis, and also active cases in the some mobile items under the our association activities. And here what I would like to query about it may be not very important, but now we have some wording, and active case finding is quite okay. And now we have accelerated case findings and then intensifying case findings. I would like to query about what is the difference between the some. I would like to know your the ideas and your suggestion. What about the difference between the active case finding, accelerated, and intensifying case finding? Yeah, thanks, sir. Yeah.
Intensive case finding, we say, suppose like in a health facility, general health facility, where a lot of patients are coming, they may be having symptoms. Like in maternity OPD, gynae OPD, antenatal case, you can find out in the waiting area who are the persons having symptoms suggestive of tuberculosis. So these are the health settings where we conduct active case finding. So in a health facility or health setting, like they say, if there is a medicine ward, you do sputum examination, everybody. Many studies have come, and you can get many TB cases from them. So intensified case finding is defined as a setting where we presume that TB cases might be more than the general population. So if we do any activity, that will yield more cases. While active case finding is when we are giving to the community. So that becomes active case finding. Community means any vulnerable population in the field, not in the institute. In institute, it's become intensified case finding. Like in ART clinic, where patients living with HIV are coming, you can do intensified case finding. Passive case finding is whenever any persons come at their own to health facility to get it tested. Like in any OPD, we say in any OPD, If a medical officer is seeing patient, if he has got any symptoms, send them to us. So that is a passive case finding where patient is coming to us. Intensified case finding, finding cases in a high intensive cases, institutes where there are chances of getting more cases. Active case finding is the field.
Please.
Thank you very much, Doctor. My name is Bashir once again from Uganda. I have a keen interest on the data you presented regarding the prison and the inmates. I saw very high incidences in the prison, and we all know that the prisons are not permanent places. At one time, someone has to come back to the community. In terms of policy, I want to understand, is there any policy designed or formulated to ensure that whoever is coming back to the community, they are safe? Or I can see that there is a risk of transferring inmates back to the society when they are not, when we're not sure of their status in regards to TB. Thank you.
So before conducting this active case finding in prisons, we did two studies. First was two interventions. First was the sensitization of whole of the staff. Second was to see the ground situation. So what we were told that any person who is entering in jail, prison, they get their XHS done to rule out any infectious disease. That is a government policy of Government of India. But how much is that working? Nobody knows, because when I conducted the study, out of the 12 jails, in 7 jails, X-ray machines were not working. So we made an extra effort to get their X-ray machine repaired. So that was a one issue. When we ask what happens when patient is discharged, so there are two types of patient. One patient, they are in the DOT center, which their doctors have diagnosed, put on treatment with the help of DCTV officer. They have got their full address. And when they are discharged, they are properly referred as patient is referred from one area to other area. Means patient is being transferred to other area. From this center, patient residing in other city, they are transferred through, one thing is through our Niksha. Our Niksha is an online portal where entries of all the patients who are diagnosed and put on treatment are done. When we know this person has shifted, the data entry operator of that chest clinic will write that this patient has come to the area. So that DTO, that will mark to that DTO of that area, and they can trace that patient. That helps when person is already on treatment. In active case finding, what happens? We have diagnosed the patient. We have taken their address. Whether it is proper or not, we do not know. So what we operational work, that was our second objective of the study, that not only have to do active counseling, we have to make an operational framework. Before patient is released, TB person who is sitting, TB health visitor or health worker, they should contact with that patient so that they can take up their address, they can make up transfer slip, and then patient should be advised. Whenever we transfer a patient, we used to make 3 slips. One slip is given to the patient that you go in your area, report to the district TB officer. Patient may or may not report. Second sheet, what was there, transfer sheet, we send by post to the district TB officer. This patient has left from my district. This is his address. He has taken so much treatment. So if patient doesn't come to the other area, district TB officer knows that in my area such person has come, he will send his worker to contact that patient. This only happens when we know when patient is living and where he is living. So what we tried, that we tried before releasing the patient, either do not release the patient in the evening. In the morning, our staff will be there, they will send. They said it is not possible, court orders are, we have to follow them and release at that time. Whenever they release, there is a computer data where they release, we mark red among the patients which we have diagnosed. We said them that if a person is, person's name is marked as red, he is a non-TB patient, you can hold that patient, even they didn't agree. So there was no point. The only thing was when we were starting the treatment at that time, we were advocating the patient or advising him, whenever you leave, you go to your area center, show them this card which we have given. We give him treatment identity card, TB identity card. Show this card to the district TB officer where you are, you will get treatment. But these jail inmates, they are not, we cannot rely on them, so that we could not get feedback whether they have reached or not. But some policy should be there.
Yeah, please.
Thank you very much. My name is Henry. I come from Ghana. There are three things I want to know from you. One of them, you mentioned same-day initiation.
Same-day initiation, yeah.
Same-day initiation. And I just want to know, in other disease areas, we know that default rate, when you do same-day initiation, especially in the area of HIV care, sometimes the default rate, it's a little high. Want to know, I know it will not be perfect, but how have you been trying to manage that? The other thing is about the sex workers and how you have tried to ensure that they can continue with treatment. In various countries, including my country, I mean, sex work is criminalized. And you have police raids and other things that affect continuity of treatment of any nature. So how have you been trying to deal with it? And my last question is, you kind of explain how you can follow the clients, the patient, using what you just described, I mean, the ID system. I know that India is kind of ahead in terms of, your ID system and how you've managed to really do that. Do you have a connection with that ID system in terms of how you track TB patients that had to go on, especially because you are doing outreach to socio-demographically disadvantaged groups that you described?
So you have said 3 questions. I think that requires 4 answers. 1 question requires 2 answers. First, what was your first question?
It's in connection with
default. Yes.
Same-day initiation
Same-day
and
treatment.
default rates.
This we learned from our experience. Whenever we are working in mobile population, homeless population, night shelter population, the problem is we do not have their address. Suppose I say that there is a disease in X-ray, and I tell them to come to sputum examination tomorrow and day after tomorrow, and 4th day I will start the treatment. I think I will lose 80% of them. They do not have any address. So what we followed, the moment X-ray is done, we start in the morning 8 o'clock. Team starts in the morning at 8 o'clock. One person is enumerated. He enumerates the persons which are living in that area where session is planned for that day. Second, do symptomatic screening. Pre-designed questionnaire, doesn't take much time. If there is any symptom, that ultra portable machine is there, immediately get X-ray test done in the field. Within 5-10 minutes, that comes in this mobile. I report that X-ray, it is TB. We do not wait for results of molecular test, because if on radiology it is TB, even if molecular test is negative, we will be starting treatment as clinically diagnosed. So if it is clinically diagnosed, same day, the other van which is following with the drugs, they give treatment to that person. First dose, make their I card, give them I card. There are 2 night shelters where we can admit such patients. They admit, the team, NGO admits the patient for 2 months so that they become negative, they are not infectious. Secondly, if a person continues treatment for 2 months under supervision, it is ensured that even after symptomatics, they get much education that they will continue treatment. Another thing, the initiative which we have taken, if a homeless person doesn't get admitted in night shelter, with the help of police, Delhi TB Association, there is a TB association in my state, they give an identity card, which police knows that we give them the identity card. Many times what happens, homeless people are on the footpath. If there is some politician is coming, some function is there, they throw away from that place. They make them run away from that place. So if they see that card, that this is a TB patient, we ask them on TB patient phone number is written, they give us a call, we provide treatment wherever they are, either in the police station or in any other area. By that time, we are tracking. If we have started same-day treatment, means there is entry in the Nikshay, we say. Nikshay is our online portal. That is Government of India portal for TB program. Every patient who is tested with molecular test, that person's details are entered. Suppose results comes to be positive, patient doesn't come to collect report, we can trace that patient. Whenever patient is started on treatment, that patient's details are entered on the NICSHA. Adherence is entered on the NICSHA. So patient is not coming or has gone to other place, DCTB manager of other state can be informed that such patient has moved. And fifth activity we do with the NICSHA, we are giving cash incentive of rupees 500 as a nutritional support. So that is also given through NICSHA by direct bank transfer. So that is why same day treatment is helping us to take care of initial defaulters, means before starting the treatment. After starting the treatment, if there is any chance of default, we take help of this NICSHA system. Third is at the starting of treatment, our health worker and medical officers give them counseling. Two important points are treatment is to be continued for long. Even if they become symptom free, it is at least for 6 months, otherwise they will get relapse. Second, we tell them if because of any reasons in metropolitan cities, there is a lot of migratory population which is coming to nearby villages or states for work. So whenever there is a problem in their home, they go back for even months. So we tell them, don't worry, if you have got to your home back, we will give you 15 days drugs for the transition period and a letter you show to the district TB officer of your area, you will get treatment from there. So by these two methods, we take care of default and coming to your female sex workers. It was very challenging. In jail, I could visit jail 12 times in 6 months to supervise the activity. In that area, I could not get access. Only my coordinator, with the help of NGO, he could get an access. Very difficult to talk to them, very good to convince to them. But one thing is very important, which I experienced. If you talk to them one-to-one with the help of peer, you will get succeeded. That is why all the 12 patients who were detected, I know their names and I know they have completed the treatment. They needed to come to me. Their drugs are supplied to the peer from the local dot center. They used to give the drugs, fill up my card. At the end of treatment, peer brought that card to me, got her incentive of treatment completion, things finished. So one-to-one interaction, even in the prison, whenever I went there, done one-to-one interaction, that was helpful. But in group, very difficult. Like in jail, it was really difficult. I could not make any operational framework. I tried at 3 levels. At the level of jail superintendent, could not help me. The area where all the record is there at the time of release, they check all the records. They give them some money also for the work done during that period. They've got all the details, but they were not willing to accept this TB details. I don't know why. So at that time, convincing the patient that how it is important to continue medicine, that helps. Any other question left? I think I have answered your all points.
Good. Dr. Chopra, thank you very much. Your presentation evoked a lot of interest in the best practices. I also want to tell all of you that Dr. Chopra and Dr. Ashwini Khanna, they also run a journal called Indian Journal of Tuberculosis. If you want to publish something, you can send it to them, your articles to them. Yeah, please.
Thank you, Doc, for the presentation. Usually we think that people who are leaving the prison will bring tuberculosis out, they'll bring it home. But do you have a policy whereby if I'm going to be into prison tomorrow, am I screened because I may be bringing tuberculosis from home right into the prison?
The jail manual in India, the prison manual says that any person who is coming to the jail, he should get an XHS done to rule out any infectious disease. That is the policy. But to what extent it is being followed, many times it is doubtful. That depends on the availability of X-ray facilities all the times. Sometimes machines are not working or something. Otherwise, this is a government policy.
Good, thank you. Thank you very much. Let's give him a big hand. I'll introduce our next speaker, Dr. Ashwini Khanna. Dr. Ashwini Khanna is a pulmonary medicine specialist, pulmonologist by profession. He worked in a tertiary care hospital for almost 40 years as a clinician. He was also the provincial or a state TB officer, as we call, for almost a decade. So that is when he did both the things. He did also ran the state program as well as he continued with his clinical activities. He has also traveled extensively for TB work in India and abroad. We used to call him National State TB Officer, so National Provincial Officer. So over to Dr. Ashwini Khanna for his talk. Yeah.
Thank you, Dr. Kuldeep, for those fine words. Can I use this mic instead?
Yeah,
huh?
sure, please.
Yeah. So the fine words, what you spoken, let me hope that I live up to that expectation. And I think we all here because of how we are glued together for looking to see that TB ends as a menace in the world. I mean, it is a problem. And it's nothing recent, like Dr. Kuldeep said, it's all been down the ages. And what we have seen is that in last 200 years, the number of deaths by TB, supersedes the death by all the other infections like smallpox you had, in those times which were the killers, and malaria, plague, influenza. So this wasn't a major killer. No disease has killed so many people. It's called the captain of men of death. And still it remains the same. When you see TB as infectious disease among the 10 top killers in the world today, in between we had okay. And then, with the COVID coming in, there was maybe it took over for some time, but now TB still is the single largest killer. Which one is it? That's the one it Okay. So when we see the estimates globally, India is, of course, the capital, the TB capital of the world, where, in spite of the population being the highest in the world, we contribute nearly more than 1/4 of the patients, both in drug sensitive and drug resistance every year. And when we look at the latest figure, come to the next slide. We see of the patients which have reported for tuberculosis worldwide, there were last year about 7.5 million cases in 22, the latest TB report. And this is of the total number of 10.6 which were expected. So there's a gap, there's a large number of gaps which are the missing people which still exist in the world. India is India is one country which is doing well in that place. On to the next one. Can I move this slide instead? Okay. So when we see the TB estimates in India, the latest TB global report says we have incidence of 196 per 100,000. A large number of patients are there because of the number, the size of the population, and you see the incidence, it boils down to a number which is roughly 2.7 million of the expected cases are there in 2022. But what we have achieved is we have been able to detect 2.42 million. The gap which was existing earlier has been, the gap has been decreased. We had a missing million. Now we have hardly a percentage which are missing. Among the patients who have reported, HIV is not really a driver of disease in this country. It's just 2%. And even DRTB, roughly 3% of the patients are DRTB. However, what is affected is the productive age group. When you see the productive age group, 65% of the patients will come under this productive age group which is affected. There's a 15 to 45 years of age. Males predominate, children about 6%, and it's basically a disease of the rural area because large percent of the Indian population stays in the rural areas. Why is it moving? No? You're moving. Okay. So when we see the notification, what we see, the notification of TB in India has gone up over the years. 2015, when we started the, in a national strategic plan, you have a gap. You see the public sector was the predominant, player as far as diagnostics was concerned. In 2015, 114 lakhs, that works about 1,014 lakhs is about 1.4 million. So the cases were being reported from the public sector and a very minimal contribution from the private sector. And you look over now, nearly half of the patients are coming from the private sector, which has, scaled up our notification, which is nearing what we are looking at. We're looking at 2.7 million, and we have detected for 2.5 million. This dent has been made by the involvement of the private sector. Next. So total notification, latest figure we have is about 2.5 million. That will be at least 92% of a target, which is a achievement as far as we are concerned. And the public sector notification has been augmented by the private sector notification, which has helped us achieve this figure. Next. The incidence of the disease over the years, starting from 2010, has shown a gradual decline. We can see that. Now we have something like a figure of 199. And as far as new and relapse cases come, we have a gap which is narrowed. You can see there was a missing million initially as far as the incidence and notification was concerned. And this gap has started narrowing down and is really narrowed down now. HIV TB positive incidence also has gone down tremendously. Amongst the mortality over the years, which has shown a gradual decline, we can see that the mortality has reached the mid-20s now, from higher 30s in 2010. Next. This is what I'm telling you, what we have achieved in the last few years, and what has helped us, push this program is, of course, the political commitment. You can see the person at the helm of the affairs, our Prime Minister, Mr. Modi, he has been very vocal about all of this. We started with having an NTB summit in Delhi in 2008, which was a landmark summit, which set a trend with the political, involvement and push, which was never there earlier. Then it was followed up by a very important summit, which was the One World Summit in Varanasi in 2013, where this was committed. This was reaffirmed that we have moved towards ensuring a TB-free society. This is India's efforts for a model for the global war on TB. Next. Now, how do we achieve this? We have a strategic plan, 2015-2025, and it depends on these strategies: prevent, detect, treat, and build. And now, amongst the strategies what we have in the prevention is TB preventive therapy. Of course, this is one aspect because in India we have about how much will be about 40 crores workout. 500 million people are infected. They're carrying the bacilla with them. So that's a very large number. And this is a pool of persons who are going to break out of disease. So preventive therapy in a graded manner, starting from the ones who are most vulnerable to get this disease, moving to the other group, is there in place. We'll just talk about it later where we have achieved. Then you scale up TB infection control. Now this TB infection control needs to be done both in healthcare setting as well as at home, because the patients are going to go back home. When they go back home, they're going to infect the people at home, and they are going to break out the disease. So this has to be taken care of. Then detect strategies. This is to scale up the setting for, for diagnosis. We are using the high-end molecular tests like both the MAT as well as we are having the culture facility. Now this has made a large difference as far as we are concerned. I remember when I started my work, we just had a diagnostics with sputum and ZN staining. But over the years, this is one strategy which has really made a tremendous difference as far as diagnosing and treatment is concerned. More than that, it gives you a lot of confidence that we're dealing with the tuberculosis case, not anything else. Then intensified TB finding that I think what Dr. Chopra has alluded to. Then we have various strategies for treating both drug-sensitive and drug-resistant TB. Drug-sensitive TB, there's nothing much change as far as drug is concerned. But in drug-resistant TB, we are following, we'll just discuss that also, how our policies have changed over the years, moving towards treatment, which was for 36 months, down to for 6 months now, and how our results have also improved the time, with a success rate hardly crossing mid-50s to reaching up to 75%. Then you have a build strategy. We have a fully funded program, multi-sector involvement, surveillance, human resource management, private sector engagement. This is one private sector engagement which has again made a dent as far as finding the cases and treating the cases and support we are giving them, how it has helped us achieve what we have achieved so far. Let me move to the next one. So this, I brought this slide here just to show how these two molecular tests are helping us find the cases. They have detected nearly 60,000 patients of MDR TB in our country. And this more than detection, that besides MDR TB, how many other TB cases have been detected can be seen there. These are few tests which have really revolutionized the treatment, I think, the world over, and given the confidence in treating the disease. Next. So we started. This is what I think India can boast of is our mixture platform. We started the program in 16s, and we had a paper-based reporting system initially. And in 1998, when we launched the National TB Elimination, RNTC, the Revised National TB Control Program, it was a DOS-based epicenter. In 2007, we moved to the window-based. However, here in these three systems, it was aggregate data, which was picked up and entered into these platforms, and it was submitted on a quarterly basis. Then we have a web-based, and now we have a Nikshit 2018 with individual patient data from the health facility onwards. Online real-time entry is done and patient tracking and care cascade is monitored. So this is something which is, I think the world is looking at how we are able to achieve the tracking of the patient. And a lot of our activities like looking for a drug, for tuberculosis preventive therapy, monitoring, everything is subsumed into this same platform. So this is what has really helped us, achieve what we are moving towards. More than that, we need involvement of medical college. Now, medical college is the people where the people are studying, they're learning about TB, and they have to be actively involved rather than leaving the program to the program managers in the periphery at the district level. The training, the teaching, the interest of these group of people who are teachers should also be fundamental. And for this, various gazette notifications, a letter from the, Government of India, and to the, even to the National Medical Council, that this has to be done, help us, achieving and involving the medical colleges and hospitals to support the formation of what is called a drug-resistant TB wards, which were very difficult to form. Very few people were willing to take it up, and at times it needed a scale up. So this was what needed, the push was given through this. Next. Okay. So now strengthening of private sector, like I said, private sector involvement was the one which has pushed up the involvement, the notification of TB. When you see the right, there has been a 92% increase in private sector notification. It has really doubled from 2017 to 2022. Now, on notification, this is what given a push. Earlier, we know the patients were getting treated in the private sector. Whether they were taking drugs, we are very not sure. Whether they were completing the therapy, not sure. But with this, involvement of the private sector, it has become what we see what it's now. And this is by mandatory notification about private providers. You had a notification that it became a punishable offense. It is a punishable offense if you don't treat if you treat a patient and don't report it. Now, Schedule H1 implementation was done with all these private practitioners who were treating patients. They could take up the drugs, free fixed drug combinations from the government and give it to the patient in the private sector. Now, the support of patient provider support agencies through the joint effort for elimination of TB and domestic resources was there. So this was the link between the private sector and the government sector, so that they can support them in achieving and doing the work for notification, putting on treatment, and coordinating with government agencies. And there is a guidance document which has been given for 2019, and this helped us having more involvement of private sector in this process. Next. What I'm trying to tell you, how the government has pushed towards, getting TB detection, TB treatment, and involvement of all the sectors, so that we can achieve the move towards ending TB, looking towards ending TB. So TB gazette notification, like I said, mandatory notification. Besides being notified, being a punitive action, if they don't notify, they were given support in form of incentives. Now, this was providers were given incentives at time of notification about 500 rupees and outcome reporting at 500 rupees. To the H1 implementation, that means all these drugs which are sold in the private pharmacies, anybody buying those drugs, it is mandatory for the the pharmacist who's selling the drugs to take down the details and inform the government about it. So there's a collaboration between the various professional bodies. You have, people, Indian Medical Association, you have the people who are dealing with orthopedics, you have people with pediatrics, they have to involve so that in their meetings, they are able to tell their people who are working for them who are registered in their organization during the CMEs that what has to be done as far as TB is concerned. Next. So this I talked about incentives. These are incentives which have been given both to informants. Besides that, there is incentive not only for treatment of TB patients. There is incentive for the provider who gives treatment for the preventive therapy also, like Asha, Dr. Chopra talked about. So this is incentive given to a person who gives treatment for prevention also, not only for treatment. And then of course there is incentive for these people to make entries into the mixture also. Next. To achieve all this, we can't work in a silo. We need support of other programs. And I think Dr. Sao also brought about, I think Dr. even Amar also talked about, we need to get involvement in other programs. Now, we talk about diabetes. We know diabetes is not a major driver, but it's certainly a driver of a disease. We do find in certain parts of the country a very large number of diabetic patients. So there's a bi-directional screening. Anybody who's having TB is evaluated for diabetes and vice versa. Anybody who's having diabetes is evaluated for TB under the National Diabetic Program. Besides, there's involvement of cancer and stroke. It's National Tobacco Control Program. Also, we have what is a bi-directional screening both ways. Any patient who's a smoker, who's a patient with tuberculosis is referred for smoking cessation, and vice versa. Anybody who goes for smoking cessation goes to the clinics. They are referred if they are they are found to be having symptoms suggest of TB. Besides that, during the COVID era, we had bi-directional screening at that time also. Besides, I think all patients of TB and are evaluated for HIV, and all patients for HIV are evaluated for TB. HIV are evaluated for TB. So these are various, collaborative steps where the social determinants are taken care of, and both social as well as clinical determinants are taken care of to ensure the maximum number of patients who are there in the community are detected and evaluated and put on treatment. Next. So how do you strengthen the public sector? What we are doing is active case approach has already been talked by Dr. Chopra. But what we are doing in the passive approach, where the patients are coming to us in the setup, we are giving them upfront screening and X-ray and screening and coverage. Now we don't have to wait. Earlier, patients, this symptom, get them evaluated by sputum or by other methods and then do an X-ray. But now X-ray has become upfront, and we know a large number of patients who were screened during the prevalence survey were found to have TB when they were having no symptoms. And diagnostic algorithm, I think Goa has taken a lead in that as far as everybody is having upfront NAT testing. That's what I've heard. And that's the plan of government, where NAT will be offered to everybody at the time of diagnosis. Like Dr. Sao said, in this era, why are we waiting for, a test like sputum microscopy where the, sensitivity is just 50%. Next. Now, this is one success story we've had, at least in India. What we found was that India, the number of patients of India who were there were not fully being diagnosed. They were missing a lot. And among the ones who have been found, hardly anybody, a very large percent of them either died or they left their treatment. And the successes were very bad. So we have what we have done over the years. We have introduced shorter oral, WHO guidelines. We're following those guidelines. And we are having the oral shorter MDR and RRTB regimens in 7 states. And now this has been scaled up to entire country. So shorter regimen or oral is the treatment of choice in India for patients who can be given shorter regimen. Then bedaquiline for MDR patients in age group 5 years and above, more than 15 kg. So this is how we've scaled up. Now we are using belamidate for all patients, irrespective of age, provided above 10 kgs. And then we are also in some states started, it's not pan country, but a large number of states have taken up, treatment for contacts of DRTB also. And we have used BPAL regimens in this country. as a pragmatic trial in collaboration with National Institute of Research in Tuberculosis, ICMR, and WHO, and it has shown excellent results. I think the results show that a 6-month regimen for patients who are eligible for this regimen is as what we have got international results, over 90% success rate. So this is a document that we're looking at moving towards. It's not it was a pragmatic trial. We are looking at having this shorter regimen with both BPAL and BPAL-M in the country soon. Next. So to know again, I'm talking about DRTB because this is one area where, we have really done well in the sense that we have studies, we have done burden estimations, we have done prevalence surveys, periodic drug resistance surveys to know what was drug resistant in the country. And this has shown that about 3% of the new cases have, DRTB, and about 11% amongst the patients who have taken treatment before. Next. 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 So I come back. So prior to our regimens, we started our DOS Plus program in 2006, where the duration of treatment was, up to 24 to 27 months. And gradually we moved toward treatment of XDR. This is gradual movement up using the changing trends, the changing guidelines over time. When we started in 2014, everything with the availability of the rapid diagnostics and LPA, we changed the regimen. So this is just to show that with the availability of besides the drugs, the diagnostics, and the evidence of the newer regimens, we moved. But what it shows till 2014, come to the next slide. The results you can see worldwide were pretty bad, and India was no, surprise there. And amongst till 2016, we can see that where we have India, we have a success rate of nearly 50%. Most of the patients, half of the patients are only cured. And when we come to XDR, the success rate was nearly 1/3, even less than 1/3. Next. 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 Carry on. So this is stagnant success rate in a patient of MDR-TB using the older regimen, what we have done. Next. And this is for the XDR. The first one is MDR, next one is XDR. Next. Continue. Continue. So, yeah, go back. So now, with the introduction of newer drugs, we started introducing bedaquiline in 2016. We saw what has happened. And introduction of oral regimen in all oral regimen in XDR and MDR patients in 2019-20. What we see is a doubling of the success rate as far as XDR is concerned. From 31%, it has gone to 63%. And we are having a very successful outcome using newer drugs, newer regimens, because we put them up immediately as soon as they were made available and they were approved by our body. And even MDR, where the success rate hardly crossed 46%, 50%, we have reached a 70% figure. Some of the sites are doing better. They are even reporting up to 75 to 80%. Amongst the IMH resistance, we see a success rate of nearly 83 to 84%. This has been made, possible by scaling of the program. This is the latest one I'll tell you later. We have the number of gene experts, the CBNAT rapid diagnostic growing up, the line probe assay, the lab scaled up, liquid culture. So all these are the ones which have gradually improved over time, increased over time. The numbers have increased over time. And this has helped us achieve what we have achieved. The success rate, the success stories over maybe last 5 to 6 years. Next. Next. So this is how gradually our program has moved up. We had 2016 dot plus, and now we are looking at a shorter regimen of 6 months. Next. So what the key changes we have in the DRTB? We have updated universal DST. Now, universal DST, everybody has to undergo. All the patients who are having sputum positivity is evaluated for drug resistance pattern at the baseline itself. Shorter oral regimens are given to all the patients with MDR wherever they're eligible. No uninjectable regimens. No, it's all injection-free. Training of DRTB counselors and master trainers has been done by Tata Institute of Social Sciences, which is a body based out of Bombay. And preventive therapy is also being offered to patients of DRTB. And it's not pan-India, a large number of states have taken up. DPAN regimen has been used in India in research mode and will be moved towards in the field settings now. And improving access and quality of DB care to patients seeking care in the private sector. It's not only limited to the public sector, even the private sector is involved in treating drug-resistant TB because initially they were very hesitant. They were scared because the outcomes are bad. Nobody wanted to treat a patient who would die or who would, relapse, who will have a lot of side effects. But now this has been helped by giving them support. Next. Now, to support all these, initiatives, we need some learning methods, methodology, the training, the retraining at every level, right down to the periphery. So that we have various, knowledge building platforms. We have what is called Swast e-Gurukul, which is a WHO India's knowledge platform, which is being used for training of our staff in national program. Besides that, ECO support is there, that is expanded clinical health outcomes. It's a telemonitoring platform for learning and capacity building. All these platforms are used. Then you have a national program on technology enhanced learning, another platform, and then we have integrated government online training. So these are the various platforms which are available for training the staff, which is a large number, and it has to be done, to ensure that whatever new initiatives we are talking about are taken down right to the peripheral level. So medical colleges are the ones which should take a lead because earlier, the medical colleges, TB is some disease, one disease, large number of people don't like to treat, especially in medical college. If somebody is doing like in, cardiology, if somebody is a cardiologist or maybe a cardiothoracic surgeon, all he will like to do is, stenting and doing the activity. He will not like to do a thoracic surgery. At least in India, that's the scene. They won't like to work in a tuberculosis patient. Similarly, people who are working in pulmonology or trained in, maybe not trained in TB, but pulmonology, they like to do other things, like to treat other diseases like asthma, COPD, interstitial lung disease, all other disease. And TB was never. Now, there's a thrust from medical colleges towards ending this disease. So they should be a very active participant, active partners in all this. Next. So there's a curriculum for undergraduates, which is program specific, national program specific. It has to be included. The modular training has become a part of the, clinical rotations for interns and postgraduates. So this is what is building your people are going to come up. They should be fully oriented. Otherwise, most of the things what we talk about are taught at postgraduate levels or limited to the people who are working in the field of TB. The rest of the people were not really interested. And we have what is called a difficult to treat clinics, which are at state level, at the national level, where difficult cases are presented, they are discussed so that the learning capacity and the treatment capacity of the people, the interaction improves. They will know how to manage such cases. Such cases are done at regular intervals. And updates, a component of CMEs is always there so that every professional medical associations know what is new happening in TB. So that is the knowledge which was initially limited to a specific group of people who are specifically working on TB would like to move towards a general population should be aware and they should know how to diagnose, how to treat. And if they're not ready to treat, at least where to refer and to whom so that the patient can be evaluated and treated accordingly. Next. So single window system established. Now this is what has been talked about, the lung health, the comprehensive lung health. It's a new concept. Triaging is done at post-symptom complex. So all these are, informations which are available with the medical college. Airborne infection control is an important aspect where, people who are working in a setup where TB or MDR TB can be there or in the hospital where the patient goes. The patient may enter any general hospital and mingle with people who are there in the OPD. So that aspect has to come in that no disease like TB is brought into the hospital. So fast tracking of these patients who come inside, have a separate window for them so that airborne infection is taken care of. So there are various methods are done. And this is not only done at individual level. When a patient goes back home, he should should be taught how to dispose of his sputum. It's not that he's going to spit anywhere. So these are the part of airborne infection control, both at individual, at home level, and at the level where the patients can be going. And most importantly, the DRTB, not only for the patient's relatives as well as healthcare workers who are working in that facility. And then we have a curriculum of psychosocial studies. This is a part of the people who are doing medicine. There's a differentiated care. Now, this is a new protocol where all the patients with presumptive TB are assessing a pulmonary medicine department. They go straight where they have to go and evaluate early. Next. So medical colleges, to strengthen the medical colleges, we have a core committee, which is calendar based. We have members from different fields, different branches, maybe gynecology, ENT, cardiology, general medicine, pediatrics, besides pulmonary medicine, TB specialists. They all meet and they are updated about what is happening in the field of tuberculosis, and they are supposed to, inform their postgraduate students or undergraduate students. And we have a regular lectures and CMEs for them under the program. Department of Pharmacology and Community, they are supposed to have an annual prescription and audit for Schedule 1. What have been sold in the market to know how much is the sale in the market when you compare with how much is notification. And following this H1, notification by the, by the Department of Health, a lot of pharmacies have stopped selling these medicines because they have to keep a lot of data with that. So they stopped selling TB medicine. So that helps us in a way that very limited number of people are selling and large number of patients are coming to a government setup where they can be evaluated, notified, and treated as per the guidelines, not as per the non-standardized guidelines. Next. Somebody talked about AI. Now, AI is something which has come up in the last few years. And a last study was done on cough sounds, which was based on, pulmonary TB screening. The entire country took part on it. And what we have found out initial results, it shows 84 sensitivity and is presently under validation. So these cough sounds are basically a patient is asked to cough into a mobile, and based on the quality of the cough, they can say it could be a possible TB or a probable TB, so that we taken further for evaluation. Line probe assays, whatever we have, the images, they can be read by the AI, and image database created and model trained. So this has been done, and there's a validation which is planned. AI, as far as automated checks, X-ray, handed the devices are concerned, everybody knows it's a now in thing. Everybody's moving towards that. We did it in Delhi as the part of the PI for one of the studies. We used 3 AIs in different settings, and we found a very, high correlation between what the independent radiologist said and what the AI read it as far as active disease and inactive disease is concerned. And this was validated by doing even a gene expert on all these patients. So we have a 73% accuracy as far as this is concerned. And there is the one model which is also being developed for assess who are the patients who have a highest risk of relapse, loss to follow-up during the follow-up. So these are some AI tools which are being used, which will be used over the time after they've been validated. In India, of course, the risk factors for TB, you can see undernutrition, undernourishment is the most important. People who are in contact with TB, especially the ones who are in a household contact or a close contact, they have the maximum chance of breaking out disease. And now, undernourishment we find is the most important cause in Indian setup, rather than having HIV. Even diabetes, smoking, alcohol are much lower than undernutrition. I think this is one aspect which has to be taken care of. The government has taken care of it as far as the patient of TB is concerned, but even the household contacts need to be evaluated. This is the contacts who are underweight, low BMI, so that they can be prevented. Besides giving preventive therapy, they can be prevented from getting a disease, breakout disease in them. Next. So next. Next. So as far as nutrition is concerned, we have, what is called Pradhan Mantri, Yojana, where it is, the president you can see on the left, that's there, which was launched. And now there are people getting support as far as nutrition is concerned from, besides the CSR and the individuals. This is showing the community participation in preventing the disease, poor outcomes. So the objective is to provide additional patient support to improve treatment outcome in the patient and augment community involvement. Now, the people who are going to give the support can be individuals, can be a group, can be CSR funding, So these are the people who are supporting the government in achieving, moving towards ending of TB. Next. So this is what we have, Pradhan Mantri TB Mukt Bharat Yojana. Basically, it means that TB-free India, it's an initiative by the Prime Minister. Next. So preventive therapy is a part of a treatment. There have been some delays, there have been some, non-availability of INH for some time, but now this has taken up. We are using 3HP, and these are target populations who are eligible, and most of them need to be treated, evaluated by looking for infection by either now we have what is called site TB test, which is like Montu test or tuberculin test, and it's which is being used to detect for infection and treat accordingly. The options are 6H, 3HP. Now this has been planned because when we talk about half a billion people being infected, we know these are people, if you're moving to NTB, these are the people who need to be prevented from breaking into disease. So this is one method, preventive therapy. It's supposed to have over 60% preventive ability. So if we are able to take care of this group of patients, we cannot do half a billion in one go. It has to be based on strategizing who require it the most, like we are giving for HIV people. The close contacts are most likely to break into disease, so they're part of it. And people who are, immunocompromised, whether they are silicotics or dialysis or immunosuppressant, they are the ones who are the part of the program. So gradually we're moving up. At the moment, this is what we are doing. A large percentage of population, which is the highest risk of breaking into disease, is taken care of by giving initiate PPT. Next. So it's the bend the curve, which we talked in the morning. These are incentives we need to, initiatives we need to take. We need to have tuberculosis preventive therapy in place, and then a vaccine, which is eluding us. But India has started what is called a BCG vaccination. Next. Next. Yeah. So that is the BCG vaccination program, and it's a major tool to eliminate TB. We have to bend the curve. We need to have newer initiatives, and how it helps is next. It has a it is supposed to bring about a robust immune. It is shown to bring about a robust immune response and a good safety. It's one a vaccine. I think at the moment this is the only vaccine in the world which has been approved for TB and has a little bit of the efficacy seen in children at least. So this is one vaccine till the new vaccines which we are expecting to come in next 2 years, over next 2 to 3 years, are available. So this is what we have. And what has been shown that it has a potential efficacy of 36 to 46% following BCG revaccination. So this is the protective efficacy, and this is valid for up to 10 years. This is supposed to act and bring down the disease amongst a specific group of people. So in India, we are using this. Next. And high prevalence and incidence of TB in India, as well as increases of TB disease in household contacts. Everybody knows household contacts are maximum chance. We know by the time they're tested, in at least Indian setting, we found that 70%, more than 70% have already been affected because of the close contact. And the people who are high risk of developing a disease are the elderly people or the ones who have been treated by TB earlier. And important now to know how efficacious is this vaccine, we are conducting what is called a large-scale study in India to control TB. What is not a programmatic intervention is as far as study is concerned. So this is what is supposed to do, bring down the big curve and move towards looking at ending TB soon. Next. It has been tried in a large number of countries where up to 2 vaccines have been given. Certain countries have given 3 vaccines. So we have some results from them showing the efficacy of how effective is this vaccination. Next. So as of now, as for the latest TB report, we have a burden which is not less, it's quite significant, with 199 per 100,000 patients of incidence every year. Then we have HIV positive 3.4% amongst these patients per 100,000 every year. That is roughly about 2% of the patients. MDR incidence is low, about 8%, but when you calculate as far as the country is concerned, which has become very high, we are roughly having about 1.25, 125,000 patients every year. But the only problem what we are facing as far as India is concerned, we expect 115 1,000 patients, but we are only able to put about 70 to 80,000 patients on treatment. So there's a gap there. We have filled up the gap as far as drug sensitivity concerned, but that gap remains as far as drug resistance concerned. Then HIV mortality, we have a mortality which has shown, over the last 10, 15 years has gone down from nearly 40, 38, 40 down to 23 at present. Next. So the success rate is what we are getting is about 87% amongst the new and relapsed cases, which are registered in 2021. The reports are available now. And among the previously treated is about 84%. HIV positive is about 78%. Drug-resistant TB, 69%. And from amongst the pre-XDR and XDR, where the results were for 30%, which has doubled up 64%. So we are filling the gap between the detection and what we expect to find. The gap is gradually, decreasing. We've been looking at small gap about 200,000. 2.4 million are detected, 2.7 are expected. So there's a slight gap which has decreased from 1 million earlier. This has helped us to having a large, robust molecular system diagnostics available in the country, and it's been available all over now. And we have done a large number of these tests, roughly 5.58 million tests. And private sector notification is very important because this is where the patients are not coming from. We never knew what was happening to them. So notification has improved. We have put about 60,000 patients of DRTB on treatment. A large number of patients are getting TPT. Now the number will go up significantly because we are using 3HP and the take-up will be much better. And the availability of drug was an issue, is no more an issue. And we have a very good digital system. I think that's what is important. We know what is happening and is among the best, which we can always say is among the best surveillance system in the world. So I think, and of course, everybody has a universal DST, a large number of patients with sensitive coverage at baseline is about 76%. And money which is given to the patient, what is called Nikshay Pochon Yojana, which is another incentive given to a patient, 500 rupees a month till the patient's on treatment. And this is given every year. And about 70% of people are getting this money also besides the food the people which are coming from the support as per the Pradhan Mantri Yojana. Success rate, of course, we've talked about. Besides that, all the states are beginning incentives, to do well. Can the next one? Do that. So these are some initiatives where certification of the states are done, given to improve their, work, what they are doing. And they're given TB-free category, gold category, silver category, bronze category. This is basically incentive, which is the money which is given to the states to use. And this has pushed up the states to try to achieve a TB-free area or a TB-free zone. And we have been able to have a TB-free category in the country also, where there's 80% decline in the incidence. So based on the decrease of incidence, 40, 20, 40, 60, or 80%, we give them different categories and they apply for it and is evaluated. And if they fit into category, they're given these rewards. So this is something, incentives which is given to the states to improve their performances. Okay. So thank you so much. And this is basically just what I thought I'll tell you, what we have done and what we are trying to do to end TB. And I think a lot of what I've said success goes to Dr. Kuldeep Sachdeva, who was the National Program Officer. And the scale up of drug-resistant TB, I think he needs the clap. I know it's not a part of the thing, but I couldn't help it because I was a part of the program that time and everything was being scaled up. Thank you so much.
Thank you, Dr. Khanna, for extensively covering the National TB Elimination Program of India. I know it's a lot to absorb, but if you have some questions to Dr. Khanna, please ask. Yeah, please, one by one. I think somebody will help.
Thank you so much for your great presentation, and there's too much of information. Would have been split into two sessions. So just a comment. My first question goes to
the presenter about subnational estimation of TB magnitude incidence that I've seen for the classification. How did you come up with those numbers? And if you can also reflect the current way of estimating the TB magnitude from the World Health Organization. A second question is, with the growing science, we know what to do. We know the numbers that we want to achieve. And everyone is clear about the dollar numbers to achieve the numbers. The problem is finding the dollar numbers to fully implement the strategies. How collectively all of the TV community media are able to win the brain, the heart, the ears, and the eyes of the Prime Minister? How did you knock and able to get into the Prime Minister office? You tell them. Okay, that was his time. He'll tell us how he was able to get the Prime Minister. What are the ABCs of the ways how to really get that political attention, which for me is the biggest priority. We do have the commitments in Moscow, in New York, in the beautiful cities, but walking the talk, actually living the commitments is the big problem across the priority countries for TV programs. So how will you able to do that in Indonesia, in India, and probably in South Africa? These are the very prominent countries who are able to engage leadership. Just want to hear about it. And final question is, in the 21st century, we are observing big incidents that are contributing to malnutrition, growing conflicts, even the most civilized geocentrics in Ukraine, Russia, and in the rest of the world. That will contribute to the growing population of malnutrition. And do you think it is possible to achieve the 2030, 2035, and 2027 targets of NDT? Thank you. You raised three major questions. One was on subnational estimation. Subnational estimations are done in the same way as you do a prevalence survey. So you do a small prevalence survey at a subnational level in a small geography. So what you do is you say, okay, I go house to house, screen all household members, till I get at least say 10 or 15 or 20 patients of TB. So you now know that you got 10 patients of TB by screening, say 10,000 population. Then you extrapolate it to 100,000 population and get your estimates. So that's the subnational certification. You do it, I mean, it may not be very accurate, etc., but it gives you an idea that it's an important thing because when you repeat it, you're doing the same intervention, you can then see what is the impact of your interventions. Your second question was, how did we get PM's attention? Now, I said partnerships are a very important and involving all stakeholders, civil society. So there are certain or civil society organizations which do advocacy with parliamentarians. So we engaged with them and they started doing advocacy with parliamentarians and getting them on some forum where we were asked to address those forums. And this happened repeatedly in various provinces. So we have what is called as legislative assembly. So provincial elected leaders, we made presentations to them. National elected leaders, we made presentation to them, and repeatedly for a few years till it actually got the attention of the higher that it's a big problem. And also you have media and other your friends raising the issue in the form of articles, etc. So if you engage with journalists, we also ran a certificate course with journalists on how to report on TV. So it was a full training for almost, Bobby can elaborate on that, how that was run. Full training for journalists on how to report on TB, etc. And they were given a good exposure. And then a lot of articles start appearing in national dailies and other local newspapers on TB. and which ultimately reach where it should reach. I mean, it reach that political attention, it gets that political attention. So there are various ways of getting that political attention and the reach. And then it sometimes culminates in that. You also have to use other influencers and local people to reach to that. So that's the only way to do that. It's much easier for other countries now because few countries have already committed. Now you have a comparison or a competition, so you can do that. Now that's what the country is doing with various provinces. It's setting up competition between states. Who does better? Who does more? And some of that Chronicle will give a competition to many of the provinces in our country because let me answer your first, the last question, which was on poverty, malnutrition. So what we have done is, when I said extra budgetary resources, we have sort of convinced the health minister and the prime minister office to launch a crowdfunding campaign on nutritional support to patients. It's not a national money, it is not a government money. So we announced that people can now adopt TB patients, give them food, give them other livelihood option, support them in their journey to cure. And many people started coming forward. Like I can adopt 2 patients. I have adopted 2 TB patients and provide them in nutrition. It's a very small money which goes from one person. I mean, it's hardly say 6,000 rupees, or say roughly $15 for 6 months of support to a patient for his nutritional center. So many individuals, organizations have started adopting those patients, and almost more than half of the existing TB patients have been adopted by patients. And we are running this campaign very systematically, engaging with for-profit corporates for that. So we'll also sort of give you a best practice on how to raise money from not from for-profit organizations, from philanthropic individuals, and do the same what other many philanthropic individuals and corporates also donated equipment and machines to the national government to extend their reach. And you will find a lot of examples where even they have bought such machines in bulk and distributed to the national government, and they've got that. So we like Dr. Gonekar will now make a presentation on how he has moved from sputum smear microscopy to replacing it with molecular diagnostic entirely. So 100% conversion from microscopy to. So we are also sort of working with him on what is called as a TB-free Goa. We'll talk about how he can make Goa TB-free. And that's where we'll try to reach again to corporates and support the state of Goa and meeting some of the objectives. The way, in a small way where we can help. I mean, we can't replace government budgets and huge budget, but you can always be a catalyst in that change. We'll take some more questions and then Dr. Gonekar can take it. Yeah. Any further questions to Dr. Ashwini? Yeah.
Thank you very much. Comprehensive presentation. A lot to learn. Thank you for the good story. I noticed a good footprint of Finland. That's very good. But I also noticed that I think if I got it right, 76% of the patients have a WRD.
Yeah.
Yes. So how is the placement of Finland and why that 76? Why where is the 26?
Why is it placement? So as a conscious decision, the country has taken a decision to offer one. I mean, there's a policy decision to replace their microscopy with molecular tests way back about 5 years ago. That policy has not fully translated into practice. So nearly I think 50% of square microscopy has been replaced by molecular diagnostics. And within that, the major challenge is how do you decentralize that? So in decentralizing is where the TrueNet platform helps. It's a point of care platform. You can take it near to the periphery. You can also use it in active case finding. And a lot of things also changed during the COVID epidemic when we were looking to establish, as I said, I led that COVID response, the first COVID response. And there were very few PCR labs, and that we were looking to decentralize PCR labs, and that is where TrueNet helped the country in a big way. And we reached out to them, can you offer that test, and can we offer that, get that kit for COVID testing, and can we offer them on existing TrueNet machines? So that helped us to decentralize and expand the reach of PCR tests for COVID in one way. We had at that point of about 2,000 TrueNet. Country had just less than 10 laboratories who could do PCR for COVID at that time. Induction of TrueNet, immediately you have 2,000 plus. So that helped us to mount that response. And building on that credibility, I think then, yeah, and also it's a Make in India thing. So there was a local appeal for this. We now have around 7,000 plus TrueNet, and it's captured the imagination of the people that you can actually reach out to the periphery and you can do a true point of care test in the periphery. That's how it.
A large number of these COVID machines which came for COVID are being used for TB diagnostics.
Thank you very much. Interesting experiences that has been shared. So how much achieving like the private sector involvement in the political leadership and other experiences that you shared with us. So I just wanted to know more about how we monitor the monetary incentives to the private sector, because as far as my understanding, the private sector, including the pharmacists, will be large in number. So I would appreciate if you can share us the monitoring mechanisms and how you feel the activities have been done and how the private sector are reporting appropriately. And the other will be like, what are the regulations and reinforcements to implement the, all private sector should report any TB cases. So what are the regulations that can you share us with, that can you share with us?
Well, start with the regulations. The regulations have been, these have been gazette notification. So everybody has been told such regulations, are there. There is a punitive part. Very few people we have used the punishment as a method of punishing them and trying to get them to that. Gradually with time, this is through repeated, meetings, involvement of these medical associations of different associations, interacting regularly with these people and providing them support along with, when you talk about punitive, you give them support, the take-up has certainly increased over time. Then we had the PPSA, that is public-private sector, the engagement was there. This interface helped us also, into making sure that the private sector is contacted, because government was not able to do that. So this interface agency was helping us do that. And when they came into the picture, it became mandatory for them to, notify this patient. They have an access to mixture, and all the notifications, the diagnosis, the end of treatment are being notified on that mixture. This is part. And when they have to, when they're eligible for all these benefits, they have to do all this also. And when a person who's from maybe the district will go and keep a watch on that, whether they're doing it or not, whether they are notifying all the patients, are they missing somebody? This is part of the normal, activity which they do. And we come to know that in a certain area from the private sector, we can know from the chemist that a large number of patients are being, treated by this private sector who are not being notified. So we know that. So, but because based on all this intervention, supervision, surveillance, we come to know that most of the patients are being put. Now, as far as regarding the payment is concerned, every payment is done through a mixture, and it is done through the account. We take the account, because besides the patient, besides the doctor or the informant, the patient also gets the initiative. So we have to ensure that we have all the details, the patients, all the details, the bank details of the informant or the person who's treating them, so that when we are monitoring them on the next year, we know the patient has completed the treatment or end result has been put up, and then they become eligible for the benefits. And this is all online. It's directly to the bank. We take all the bank details.
Yeah, the answer to your what's cooking in your mind is it's a government money which is given in the form of incentives. It's easier to advocate for the incentives with politicians because they make a contact with the people. You see, it serves their end much better than it serves our end. We are passing direct cash to the people. So it will be easy for most of the countries to do that if you propose that.
Thank you.
I mean, they buy this very easily. You don't have to struggle for this.
If I may ask one additional thing regarding the immediate TV treatment regimens. Yeah, so you shared with us like you did professional research for BPOL, and I do believe it has been a while since WHO recommended to implement it programmatically. And for example, my country has implemented BPOL in programmatic implementation since September 2020, and the patients have been like completed the treatment. The patients, the clinicians are enjoying it. So what was the finding from the operational research, and why India is late to implement it? Because we imported the medications from India and we implemented it.
I think the National Technical Expert Group felt that the treatment, we should have an Indian data before we move towards implementing it in totality. So this was the driving force, and we decided that we did study the other regimens besides what the regimen we talked about in the B file. We talked about duration of therapy for linezolid for 3 months and 2 months, followed by the lesser dose. So it was not only for this dose, we did for other doses, and then the results have been made available and have been scaled up, and now the plan is to scale it up. That was the reason.
So also because we do feasibility studies, actually, it's not operational research on that. How feasible it is to implement it on ground, that's number one. Number two, also because of linezolid and all this thing, we were not very sure how the population level uptake and side effects of linezolid will be there. So we wanted to be fairly sure on those. Large country, pharmacogenomics may be different for population. Trials was not done in India, trials were done in the African continent. So there may be different genetic response to drugs in a different continent. So that was the idea behind the feasibility study and implementation. Okay, if there are no questions, let's thank him, give him a hand. I've taken Shobha's permission to introduce Dr. Manish Dhanikar. So he's currently the state TB or a provincial TB officer for National TB Elimination Program, a public health expert, very dynamic. He's committed to making Goa TB free, and you will see some of this in his talk. And he's also the first provincial TB officer to completely replace smear microscopy with a rapid molecular test. For that, even before he comes, I think he deserves a clap. Dr. Manish, please.
Thank you, sir. So thanks to the organizers for giving us this opportunity to discuss as to how we moved to upfront net in December 2020. So at that time, it was the time of COVID. We moved to upfront net in 2020 December. In between, somewhere around beginning of 2020, we were just thinking whether we should move to upfront net, because as it is, we were doing net testing for all the patients who are notified with the help of microscopy. The next question was, is it possible? Do we have that much of testing capacity the answer was yes. But we could not move ahead because we were not very sure whether we would be able to achieve it because of the challenges. When we discussed, the first challenge would be drop in the number of presumptives examined because of various challenges, because our staff was tuned to do microscopy only, and moving to upfront net would pose further challenge and decrease our presumptive testing. With this background, as we were thinking whether we should move to upfront net, because of COVID, our presumptive testing dropped down drastically. We were doing a presumptive examination of about 1,600, which dropped to one-third, 1,600 to 1,800. It dropped to 700. So as we were reviewing it monthly in the month of November, we realized that it is hardly anything. Our presumptive testing is 600 to 700. And at this point of time, if we move to upfront net, we are already at the bottom of presumptive testing. It may move further down to 500 or 600, and which we will attribute to COVID. So thinking that we will not be able to, we will not drop down much more, we thought of moving to upfront net. That time we thought we are already having enough testing capacity. Only transportation of sample would be a challenge because we had few testing machines at that time, and we had to train everybody, make them realize that they have to only transport the sample, which as it is, they would be transporting the sample for net testing after diagnosis with microscopy. Okay, so this was the background. Next, please. So we are, of course, it is already discussed in the morning that by 2025, we have to achieve elimination by 2025 in our country with 80% reduction in incidence, 90% reduction in mortality, and zero catastrophic cost. Next, please. For this, we are implementing various strategies as already have been discussed. We at that point of time in 2020, this was what we had already implemented, like active case finding, screening of comorbidity, multi-sectoral response, drug-resistant TB, preventive measures, private sector engagement, everything was in place. Only what we required as per national strategic plan was to move to upfront net. That was the only thing which was not in force in our state. Next. So as far as our state is concerned, we are having a population of 15 lakhs. We have 2 districts, 12 TB units. In 2020, we had 6 TB units, 2 district hospitals, 2 sub-district hospitals, 5 community health centers, 30 primary health centers, and 200 health and wellness centers, and 40 PHIs. PHIs means 40 centers wherein treatment, diagnosis, and treatment is freely available at the centers. Of course, the diagnosis and treatment centers are also available. Treatment is already also available at 200 community, 200 health and wellness centers. Next, please. So one more thing to give you the background. As on date, we have already moved to upfront net. Right, we received a bronze medal for subnational certification in South Goa with 20% reduction in incidence last year. We have implemented TB Mukt Panchayat for community engagement. We are providing infection control kits to all our patients. We were the first state wherein BCG vaccination was launched. And one more initiative we have taken up last year in October 2023, that at the end of treatment, we used to be doing microscopy as per the guidelines in our country. But we have gone one step ahead and we are doing, in addition to microscopy, we are also doing culture to ensure that the patient is completely treated. So this we have started from 23 October, and as of now, whatever samples we have done, culture has been done, we have found about 9 positive, and further course of action we have been restarted on treatment. We are having 24 designated microscopy centers at that time in 2020, and they continue to be the same. 24 designated microscopy centers only, because we have shifted to upfront net. We have not increased the number of microscopy centers which we are using for at the end of treatment. We are doing microscopy, not for diagnosis. 20 net machines we are having right now. We have free X-ray facilities available for public as well as private patients. Free X-ray, free net facility for private patients as well. We are having culture DSP lab and at medical college, and 2 DR drug resistant TB centers, and 1 in each district. So how we moved to upfront net? So at that time, as I already said, that we were having enough testing capacity, but not enough testing centers. We had testing centers only at 5 places: district, sub-district, hospital, and medical college. Rest of the places, we had to move the sample, transport the sample, which we knew already that would be a challenge. The second challenge would be the laboratory technician accepting that they don't have to do microscopy now, but they have to send the sample for testing for net. This was our biggest challenge, which we could foresee. So we planned accordingly. First thing we did was, at that time of COVID, we used to do video conferencing. So we had a training for each of the in charges of the peripheral health centers. Each of the in charges, we had a video conference, and we discussed this plan that we are moving ahead with replacing microscopy and net test would be done. Second thing we did was, we have a nodal officer for each primary health center or each peripheral health center. We have a nodal officer. We had a VC and training for them. That was the second thing we did. Then we had a training for lab technicians and told them, informed them as to how we are going to shift from, why it is important to shift from microscopy to net, and how we are going to go about, and how to transport the sample, to see to it that it is transported immediately. We discussed this. So this was the first plan what we did. Okay. And we linked each of the primary health centers, each of the peripheral health centers to a net site. So it was predefined that where they would send the sample to, whether they would send at medical college or district hospital or a sub-district hospital. This was totally, plan was prepared and shared. So that sample is, once it is collected, then it is transported to that place. So, and then we started this upfront net. We stopped doing microscopy and we would straight away going for net testing. So the moment we did this, we had to face some challenges. Of course, first one was drop in presumptive TB examination, which was not that significant because it was already down because of COVID. Second was, some of the centers were still doing microscopy. So we started doing weekly monitoring to see if any of the testing was done for any of the testing was done using microscope. So that was the monitoring was the next thing we did. Third challenge was quality of sample. We had to get a good quality sample. So this was another challenge. So what we did, we prepared a video as to how to collect a good quality sample. And then it was circulated to all so that we get a good quality sample. It was done in local language. So this was the microplan and presumptive testing. The next thing what we did was once this plan was in place, it took us about 2 to 3 months to see that we stick to the plan. So that some of the centers were used to sending the sample to medical college only for drug. Since we were doing the net test over there, everyone was aware that it is being done over there. So some of them still were sending to medical college. So that realignment we did. That was another challenge what we faced. Over a period of time, we asked for, once the COVID wave subsided, we asked for those machines which were used for COVID testing to be given to us for the NTP program for testing. So over a period of time, we have succeeded to get quite a number of those which were procured for COVID. Then we at that time during the training we prepared another format for diagnostic algorithm wherein microscopy is removed and net testing. Can you show the next slide? Yeah. So net replaced by net. So these changes we made and we printed this and we circulated this at each and every PHI, placed it in the laboratory so that it's a ready reckoner and our staff follow this guideline. That yes. The next every monthly meeting we had to monitor quality of sample. The quality of sample when we moved to offline net, the quality of sample, only 30% of the samples were of good quality, 30%. Now, the good quality samples are about 98 to 99% over a period of time. So this is another challenge what we faced because most of the times we used to get salivary samples, not sputum as such. So once we moved to offline net, after planning, we executed. Then what challenges we faced, we addressed them and acted accordingly. The next challenge was to sustain doing net testing. We didn't want to shift back to microscopy because over a period of 1.5 years or 2 years, we were sure that we can go ahead and do only net testing. Now the challenge was ensuring good amount of supplies, cartridges or chips to ensure that the net testing continues and we don't have to shift back to microscopy. The presumptive TB examination rate dropping was not a challenge after 1.5 years, but the challenge was to ensure that the supplies are maintained. So we ensured that we get enough supply through the central TB division, or we procured locally as well. Yeah. So in 2020, from six net machines, we have moved to 20 net machines. Every block is saturated with a net machine. And our next target is to see that we have a net machine at every PHI, which are 14 number. So we have to add 20 more So we have taken support of through CSR fund. Some 2 machines have been procured through CSR fund. 2 machines are going to be procured through 15 Finance Commission funds. And we are going to saturate every PHI with a net machine. So one more thing, how we one of the steps how we increase the number of net machines was every month we are monitoring the number of samples referred by each of the centers. So when it is observed that when we start PHC, we equip the PHC with a net machine, the number of presumptive examinations rise. So this we made every in charge of the PHI understand that if you have each PHI is given a target of referral. So if the PHI is equipped with a machine, then the number of presumptive examination rises. So this every month we are making them understand. So the in charge himself gets motivated and gets somehow gets a machine either through CSR funds or through some other fund. So as far as the how it is benefiting us. So from 2020, our presumptive testing has from 780, it has come up to 1,909. And our notification is, please excuse me, the 2022 it is 134 only. So it is 130, 134, 134. So the number needed to test has gone up. It's in the next slide. So our presumptive testing has gone up. It did not decrease in 2021 as we had thought of. And it has moved up to 1,900. And our target for the next year by 2025 is 3,400. If we equip all our PHIs with net facility, then definitely it is going to increase faster. Next. So our number needed to test was 12 and 11 in 2021. Now it has gone up to 22. So after we moved to upfront net, one more change has taken up is that when in 2019 and before, our maximum number of notifications would be from medical college. Okay, so 70 to 75% of our notifications, patients would be diagnosed at medical college. And 25 to 30% of the patients would be diagnosed at peripheral health centers. Now there is a change because every PHI is equipped with net machine. They are diagnosed early and the number is almost 50-50. Or sometimes it is some of the months it is 60-40. 60% of the patients are diagnosed at peripheral health centers. Previously, the same patient would come to the peripheral health centers, we would do microscopy. And then the same patient would go to medical college, tertiary level. Now, the diagnosis is at primary level. So the number has changed. The percentage of diagnosed patients has changed compared to what it was when we were doing microscopy. So that is one more change what we can see for ourselves. I don't have the statistics right now, but the next thing is number needed to test is 22 as of now. Yeah. So we are also doing other sensitivity for other drugs as well. So 95% with, please, next. Yeah, one more time. So we have 95% valid result for rifampicin and 71% for other drugs like fluoroquinolones. Next. Next. These are our challenges. Now, the daily transportation of sample will continue to be a challenge because some of the times it is not possible to arrange for transport, especially in absolutely rural areas, to transport the sample to net site. That's why we want 100%. We want all the PHIs to be equipped with a net machine, all 40, so that they can be linked to all the health and wellness centers. And second is private sector. Although we are giving free diagnostics to private patients as well, still the number of samples received from private to our net site is still low. Next. 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 So to overcome that, flyers we circulated to private practitioners. This was the during COVID, when we shifted to upfront net, we had 6 net sites. So that was the flyer we circulated at that time to private practitioners and to everyone to know that they can transport the sample to the net site. And we also engage the services of patient provider support agency PPSA to obtain sample referral from private practitioner to our net sites. Of course, we are screening for comorbidity as well. Next. So we also do quality assurance through our STLS, means senior treatment lab supervisors, who are assigned the net sites for monitoring every month, sometimes every week or every 15 days. They visit the site to ensure that the testing is done properly and reporting is done properly, and to see if there are any quality issues. They monitor. External quality assurance for net is also being carried out. Next. Next. So we are going to move, these are the next steps, which are we are going to move to industries for screening of their workers. Then handheld X-ray is already made available in both the districts, and we are going to move ahead with that. And these are the way forward. And the next thing is that we are doing, as I said, at the end of treatment, we are doing culture testing, which we will continue to and see that we will have some data, maybe another 1 or 2 years, and which we will be presenting for such conference organized by the same team, maybe after 2 years. Thank you. Thank you so much. Thank you. So the most important thing is will to do it, good leadership, resources, and multi-sectoral collaboration. Next, please. Next. Next. And this is the team which showed courage at that time in 2020 to move to upfront net. And we are fortunate that we could go ahead, sustain, and never dreamt that I would be present over such a forum to discuss this amongst 35 countries. Thank you to the organizers. Thank you so much. Thank you. Thank you. Thank you.
Thanks for the minutes for your presentation. Yeah, I know that the time is very limited, but this is very important for you, for the university UST, and according to our applicant trend. According to your experience, you mentioned about some challenges for the children's specimen, something like that.
I agree that the student specimen are the quality. That's the main thing is the relating to the gene testing. What about the some student uh, expectation limitation attributes? For example, China TB cases and extra pulmonary TB cases. Is there any limitation for the gene expectation? Another thing, one question is that now you are using it is the conventional gene expectation or gene expect alpha. Yeah, so that's because in our country, there's something we are the long starting the using of the utilization of the in ultra instead of the conventional. But that is why I would like to know the what about the EP cases and cavity cases for the clinical testing. Another thing is the type of the clinical temperature. Thank you. Quality of samples, I was referring to sputum sample only because we are obtaining sputum sample. Our structure is such that we are obtaining what we are collecting sputum samples from the peripheral sites and transporting it to the net site, which is within a range of about 4 to 5 kilometers now after having 20 sites. So as far as the extrapulmonary samples are concerned, the procedures are carried out in medical college and district hospital only. So there is no question of the transportation of sample. The lab is in the same building. So I'm not talking about extrapulmonary samples, the transportation and quality. So it is over there only in the same building. The second question is we are not using ultra. We are not using it. So gastric lavage is done. Gastric lavage is done. On the previous day, the child is admitted and gastric lavage is done. Gastric lavage, and that sample is taken. In this sputum also.
Yeah, thank you actually for the good presentation. Mine lies on what are the specific actions that actually maybe the government and the state has taken. As I'm from Africa, where we have a high TB burden also. The big worry with the 100 shifting to molecular diagnostics comes to availability of reagents actually continuously. That needs a sort of sustainable plan. So I wanted to lean around that corner, what has actually happened specific to that. And also, if we can mention something about how easy or difficult has been to maintaining the equipment, ensuring that they're up and functioning for 100%. Thank you. Just those two points.
As far as the maintenance of the machine is concerned, we have a CMC, comprehensive maintenance with the company. So they take care of it. Let's say if it is TUNET, our Malbio Diagnostics, they take care of the maintenance. It is a comprehensive maintenance of the machine. So that's not a challenge. The first question I think that
the first one was around ensuring availability of supplies.
Supplies.
Yes.
Supplies. So ensuring supplies is our central TB division. They supply the cartridges or chips which are required. Also, we have funds allotted to purchase it directly from the vendor. So only we have to ensure that we have to calculate what is required, what is going to be our presumptive examination over the next 6 months or a year, and procure it in advance. Because the procedure to procure takes a long time. So we have to calculate and arrange the logistics and plan the logistics in such a way that there is uninterrupted supply. It's a challenge. It's a challenge because it will take quite a number of days or months to get approval. So you have to plan in advance. Like say for example of our presumptive TB examination from 800 it has gone to 1900. So when it was 800, the supply say for example was 5,000 2-net chips or 5,000 cartridges. Now it is 3 times. So I have to foresee and plan in advance that it will be so much and each of the centers will require so much. In addition, suppose the active case finding is done or some camps are held wherein quite a number of samples will come. So suppose it is utilized, then I have to see for myself the requirement would be different. It would be much more. Or if you are planning some intervention, how much resources are required? You have to plan in advance.
Thank you, sir. Thank you for sharing your success story. It's actually very motivating and also gives us food for thinking for countries like us. So I just have 2 questions regarding the sputum transportation. What modality you are using? Your HR is used as portal for carrying the samples, or is there any other courier system or anything else? And what about the transportation? Means are they using the public transport or they are given with their own vehicle for transporting the samples? And second one is, I know you are using MTB lead cartridge, but what about the isometric testing? Are you using the XDR cartridge as well or not? Thank you.
We are not using XDR cartridge. We are using LPO, doing LPO.
Okay.
And the transportation of sample, we had thought of engaging a courier service, but it is not materializing. So we are using our own transport of the facility, wherein the sample is collected and transported. The challenge over here is at times the vehicle is not available because it is used for multiple activities. That's a challenge. So because of that, we have ensured that if first option is to use the facility vehicle or use the vehicle, you can carry out multiple activities at a time, plan in such a way, the PHI can plan in such a way that when some other activity, for some other activity, the vehicle is being used and going in the same direction, it is, we collect the sample and take. But if we rely on this, daily transportation is a challenge because they will collect the sample, keep it in the refrigerator and send it as and when they think of sending it. So for that, we started monitoring and visits by STLs, senior treatment lab supervisors, to go and look in the refrigerator if anything is pending. Okay. So the next option we have given is that we have given funds for that PHI to ensure that if the vehicle is not available, then a staff can take the sample in his vehicle or her vehicle or the public transport and ensure that it is transported on the same day. That's it? Yeah. Anything else?
Hello, my question is, what can be the role of TBKVP in communities in laboratory monitoring? This question is coming from CLM, community-led monitoring. We are doing a lot on community-led monitoring, using one impacting countries, but if you look at the indicators, you'll find out that nothing is linked to DHS systems in countries. And most of the things we track, always we find number one will be medicine stock out. But the ministry is doing the same. It's taking the same problem. And normally we report medicine stock out, but in most cases it will be distribution of medicines, which comes with a lot of catastrophic fees among KVP, but it will be not really stock out for the nation. So my question is, how can we be part of the diagnostic monitoring and also come up with indicators in our committed monitoring on laboratory and diagnosis agenda? Every agenda on diagnosis and laboratories, it's also always referred as it's technical. It's technical. Hence, communities and KVP, we are out of the agenda. So my question is, how can you be part of the agenda? Not just awareness, but enhance community-led monitoring. Because I'm discovering that diagnosis is key. No diagnosis, no TB agenda. Thank you.
So we have already taken this step. If you see one of the slides, we have implemented TB Mukt Panchayat. TB Mukt Panchayat, wherein community, that the local panchayat or the community participates, and each of the panchayat would be the driving force. Like now we are talking about TB free India. So TB free district, TB free tuberculosis unit, so TB free village, TB free panchayat. So it is percolated to the ground level. And there is a criteria where, which defines what is TB Mukt Panchayat in a small area of, say, or a village. What is the criteria for, we have defined what is the criteria for a TB-free village. Over there, the community participates in deciding how the TB-free village would be. Like there is a criteria as to X number of testing, sputum testing has to be done. Now, if the sputum testing has to be done, there is something called as Village Health and Sanitation Committee. Village Health and Sanitation Committee, it's a committee of that village, wherein the local leaders are a part of it. Some of the experts are a part of it from that area, which meets maybe a month or every 2 months to discuss about the health issues. It can be discussed over there, and it is being discussed in those forums as to suppose there is a fund which is available under the panchayat, Gram Panchayat Development Plan. Over there, resources could be allocated. If there is no fund available for local for procurement of the diagnostic facilities, chips, it can be made available through that as well. There is a provision.
Thank you. I really also want to join other people to appreciate the bold steps you have taken in really taking access to diagnosis. And I think the post is obvious that your access is above the national level. Of course, I'm wondering what could be already the impact of this. Are we seeing early diagnosis improve indicators, mortality incidents? But my question is, you are saying you want to put the nuts all over the place, the diagnostic and primary health care. What strategy do you have to really be able to get all the machines you want? Because I think I need that secret. And are you considering placement as one of your options? Thank you. And the mobile positive towards that direction. I don't know. We have for scaling up for net and the panchayat.
So we already have 20 net machines. You are asking me whether how we are going to make provision for another 20. We really don't have a plan of action, but we are exploring strategies under CSR, corporate social responsibility, to equip every PHI with a machine. All the machines which could be spared, which were procured during COVID, they are already in use. Okay, so now getting more is a challenge unless we get them through corporate funding. That is the only option. And two, we are going to procure under the funds for from other programs, that is Finance Commission. So we will require 18 more. So we will get it over a period of time.
Thank you. I really also appreciate in terms of taking kind of bold measures to implement this not as a frontline diagnostics in your district, if I'm not mistaken. I really appreciate that one. Just I'm wondering, the major problem that we had in our country is the access. So I think in terms of your experience, you have shown us that expansion of this not would benefit in accessing those diagnostics as a front line for screening of TB cases. But I'm a bit wondering if that could be even feasible in our setup. Sometimes we measure our capacity in terms of diagnostic capacity, in terms of having the instrument and optimizing the existing instrument also. So is it possible to really expand this intervention across the countries or across all cities in the countries? And what is the way forward in terms of ensuring access? Because there is two ways. One is expanding these diagnostic tools in every health facility, and the other intervention might be to also optimize a referral system to access these diagnostics. So, and also beyond that one, I'm also questioning if there is any possibilities of this question might go for the companies. So if there is any possibilities of looking at each health facility level diagnostic capacity to place machine. Currently, I know that there are different platforms for diagnosing TB. There are, in terms of TUNAT, and also 1 module, 2 module, and 3 modules. So that is one way. And the other one is to optimize the specimen referral system. So my question is that your intervention that you have really shown us, is it really attributed to the placement of information across facilities or improvement in terms of the quality of specimen? So it will be very important for us to know whether this intervention is really attributed to expansion of the net or really improvement of the quality of the service or the specimen that is being collected. So as a developing country also, I would like to ask and see if you could share us if there is any possibilities of optimizing the access with the existing machine. And thank you.
First, we want the optimize the use of the machine, existing machine. Okay. But the challenge is we have to move to presumptive examination of 3,400, which is not possible because of transportation of sample. Because we have seen that once we equip a PHI with a net facility, the number of referrals will improve. If we want to eliminate tuberculosis by 2025, our challenge is first thing is to increase the number of presumptive examination. So if we right now, when in 2020, if the presumptive examination of say 1,000, 1,500, we had enough testing capacity for 1,500 to 1,800. We started with upfront net, then with 6 machines. With 6 machines, our testing capacity to the maximum would have taken care of presumptive examination of 1,800. Okay. So now the number of machines are 20, which can take care of say the testing of 3,400 as well. But getting these many tested would be a challenge because the facility will not be able to transport these many samples to the net sites. Because we will definitely have challenges of transportation of samples. So if we want to achieve elimination, then we have to increase the number of sites so that the facility is equipped to do the test themselves and they are confident of referral. Otherwise, suppose a patient is called with a sample today and the sample is not transported, the next day patient may or may not come with the sample, with a fresh sample. Patient is a priority. So if we want that the patient should be tested, then we have to ensure that the sputum sample is collected and tested. So because of that, of course, our thing should be that to ensure that optimize the use of the machine. Use it to the 100% capacity. But with that, going to 3,400 tests would be very difficult.
Just have one more. Just one more question.
Dr. Manish Gonikar is so popular, he will be here for the probably, so please stay for the lunch. Please keep the discussion going. One more question.
Okay, thank you for the brilliant presentation. Just have one question. Since you guys have already implemented the NAT technology, I want to find out how many samples do you people do with QNAT and how many do you do with GeneXpert? Thank you. So the number of samples. We have 4 CGNet machines and remaining are 2 net machines. So the samples are the CGNet machines are placed at medical college, 2 at medical college, and 1 at the district, 1 at the South Goa district, and 1 machine is exclusively kept for TB and chest diseases hospital. So all the samples which come to TB and chest hospital in the pulmonary department, which is separate from the medical college, all those samples are tested with the CBNet machine over there. Medical college sample, all extra pulmonary samples, we are doing CBNet test. Okay. And medical college is also equipped with a 2-net machine. Those samples, I mean, it will depend on the load at the medical college. And all South Goa district hospital, we are having a CBNet machine and we are also having a 2-net machine. So both are being used. There is no, we don't decide as to which sample should go where, unless the clinician says that we want a CBNet to be done or a 2-net, whatever to be done. I don't have the statistics right now to give you how many 2-net, how many CBNet.
Yes, one question. So much, Dr. Manish Gonikar. What Dr. Manish Gonikar has achieved here in Goa, let us hope that this happens in every state of India and all the countries, high burden countries. This is what our world leaders, the presidents and prime ministers of our countries promised in September 2023.
to achieve 100% upfront molecular testing. This was a WHO call since 2018. It's high time that we reduce the barriers which people face in accessing services which are centralized or semi-centralized. Dr. Gonekar, thanks a lot for taking these services to the doorstep or as close as possible to the people. We really want that you all should keep the interaction going. Over lunch, please stay on. And between lunch and us is only one small little presentation of Dr. Bonali Datta. Dr. Bonali Datta is the Director of Respiratory Medicine at India's one of the most reputed private hospitals, Medanta. She is also the project lead for Mission TB-Free India, which was earlier Mission TB-Free Haryana. Why is it important? Because what Dr. Ashwini Khanna Sahab, what Dr. K.K. Chopra Sahab had just presented in the morning, this presentation will clearly connect some dots. The patients, people who are homeless, who are in the shelter homes, what Shobha Madam was telling you about a patient who was not diagnosed for 1 year in Delhi because he can't even stand. And he was in a shelter home 1 kilometer away from Sir's New Delhi TB Center. Sir was the director there. He got, the homeless person was taken by a local NGO, Humana Sir. And Dr. Bonali Datta has been leading a van initiative. She takes these services in a van closer to the people so that people who are more at risk of TB can have best of possible services. It's a very small video, but probably it really underlines why it is so important. And she has been doing it since 2015. So, and this program has evolved a lot because in 2015 she was using the technology which was there. These were like huge buses. And what probably one of you, sir, mentioned about a motorcycle, right? But a motorcycle with a ProRad X-ray on a backpack going to different communities, that is really amazing in, taking the services so much more closer to the people. I remember Dr. Lalayan, are you here? Yes, yeah, Doctor, I read your tweet, and it was an X-ray machine, which was a portable backpack X-ray going in Philippines, which was really an inspiration. So something of that sort in India. Very shortly.
I would just like to add that Dr. Bonali Datta was supposed to be here with us, but she lost her father 3 days ago, and so she couldn't come. So we are just showing a short video.
Over the last
Yes.
10 years. So this is
Yes.
what we started with. Our first van, it was a van given by Siemens, and Dr. Trehan, as you know, is he is such a driven and motivating leader. And this is the first van he got us, which had mammogram and other things. We affixed an X-ray and started this. So this is in Rewari 2015. So this was the first technological procurement that we had, digital. This is just a simple portable X-ray machine from Allengers, which is an indigenous company. And then we had the digital setup already there of Fuji, and this was the X-ray that we could see then and there. And this made a huge difference to our entire thing. 2018, this was our Gene Expert Edge that came on board. And again, that made our program very meaningful because of the 10 suspected TB patients from the X-rays of that day. We could do the Gene Expert, on the day and confirm the diagnosis. And then Cure AI 2022, and this is just a picture of what we get from AI, how they highlight the areas of concern. And we can see that the left lung here is quite damaged with fibrotic lesions or infiltrates consolidation, maybe a thick walled cavity forming. And this, they'll give us a score, and the score in this case, I think, is 0.98, so 98% probability of having tuberculosis. And these are the partnerships. These are the 6 big vans we have right now. And the partnerships have been from other corporate partners. And we are really grateful for this association. RITES has given us 4 vans. Krishna Maruti has given us 2 vans. In fact, we have 7 now because they just gave us a second van on World TB Day. Hero Motocorp in the future are going to give us 2 systems. RJ Corp has given us, Siemens and Philips, they had given us earlier vans, which have, one of them has gone to Lucknow now, and one has gone to Ranchi, sorry. So this is how this, the vans work. And this is our very latest acquisition of the ultra portable, and we trialed this in Karnal, and we have started work on this. We'll have one in Delhi and one in Haryana, and we'll see how this works. The government of Haryana itself has given one ultra portable to every district, all 22 districts. So I think in the sense of technology, we are making huge strides in diagnostic, and we must we must utilize what we have, because taking this to there's just an empty village plot on which we put it up, and we had a big camp there, because all that entire village, everybody could just walk over and get their x-ray done if they had concerns. And so this is what we have downsized to, from having these big vans, which are actually quite expensive. They take almost 60 to 70 lakhs in making them, having a lead-lined chamber where the x-ray takes place. Then we came down to a ambulance size. Then now we have a car which carries the ultra portable, both the x-ray machine as well as the molecular diagnostic. And as we know, this can even be done on the back of a bike. But this I wouldn't recommend for long distances, maybe just short distances if we need to go in a very safe manner, because obviously the equipment, the ultra portable x-ray is still a very expensive equipment. And, we have to handle it with a great deal of care. So in Haryana, just briefly, this has been our expansion from starting with the pilot in one district in 2014-15. We've now covered the entire state of Haryana, sequentially many times over different districts. And this is one of our programs for Adopt a District, where we tied up with numerous corporates and encouraged them to take up a district where we would then assist with case diagnosis, help the government. And this is the cluster randomized control trial that I talked about in Karnal. And the blue, this is the sub-center, and the red is intervention, blue is control. And this is where door-to-door with the ASHA workers. And I think this is the way forward. However labor-intensive and cost-intensive it may be, but this is worth doing if we want elimination. And this is the results that we had, where we covered 3.5 lakh individuals, 3.4 lakh individuals, and there were 238 were positive, 14% out of this, cascade, and some more clinically diagnosed, 244 dots. And then we even did contact tracing. And as we talked about, we did telephonic dots. And we had much more women, 52% women, because the distance for 88% was within a kilometer. So these are very important things from the rural perspective, where distances are huge. And we tripled case notification. As you can see, there's the intervention area. And then Delhi. Now, Delhi, I think collaboration is the way forward. As we know, we have the government at the very center of it, and then the other partners must join in as best possible. Civil society partners, we are now working with another group called Humana. CES is not there now. We have PHRN. They are experts in this, in knowing what happens to the people on the street, who are so vulnerable, the key affected population. We offer our diagnostic facilities. University College of London has given us technical expertise and advice. Then TB Association of India, Diagnostics, Medicine Delivery, and of course the state NTEP, both NDTB Center and Lok Nayak Hospital. So the doctor referral and follow-up. And so this is where Medanta fits in with the diagnosis of chest X-ray. And so you can see how vital it is to have all the partners, because active case finding is done by these groups. And the recovery shelters, for the homeless people, they are taken in there, they're given 3 square meals and their medication and kept till the treatment is completed. So there's a huge need to scale this, especially because we may diagnose as much as we want, but till we have ensured that they are cured, we are not going to have any impact on the disease, on the incidence. So this is Yamuna Pushta. This is the area just on the banks where we, deal with, we have the camps. Our van goes and looks after, does the screening for homeless people. So this is one of the places. Then this is a shelter in Bangla Sahib complex where we recently did a camp. These blue ones are all the shelters. This is with the Humana team, and that's our van over there. And then we have in Old Delhi. In Old Delhi, again, that's a key area. We work in the clinic in Pili Koti and done huge number of camps over there. And so you can see that, there's a huge benefit to be getting a mobile system there. And when we station these ultra portable and move from one shelter to another, again, I can see that having such a tremendous benefit to the population that live in that area, who have, who are really very vulnerable, key affected, and they need all the kind of help and all the assistance we can give to picking up. And as you rightly pointed out, not just TB, but all the other illnesses, because these are all, they're all linked at the end of the day. If someone has TB, there's a strong possibility of them also having, any of these bloodborne viruses. So that's something that we have to keep a lookout for. So this is what is key nowadays in every setting, but especially in the urban setting for this kind of key affected population, is what we now refer as a differentiated care model, because everybody needs a different level of care. So there will be those. So we start off, we do mass radiology, and then expert, and now we have expert, TrueNut, etc., positive, negative, the microbiologically diagnosed and clinically diagnosed. Now, there are two forms. Residential treatment is in the recovery shelter, and those they can be healthcare workers who carry out community-based treatment. So this is a model that we are developing going forward. And in our screening in Delhi, as I told you, we had a staggering level of 5.4% in the first round of screening, then 9.4% when we combined it with clinically diagnosed. And currently, what is ongoing, we have a 6.8% prevalence rate, pickup rate. So this is huge in this cohort, and this cohort has to be looked after, that the diagnosis, treatment, everything has to be looked after. And this is what we launched. You can see Dr. Trehan here, Dr. Guleria, Dr. Jaiswal, myself, and the whole Medanta team when we launched our bike with the MolBio ultra portable X-ray. We have union representative. We have someone from Hero Motocorp who are funding the bike and the ultra portable X-ray. And this is the future, really, that we take the diagnostics to the doorstep of the patient. And, I think we have great hopes of what we can achieve going forward. I think that is my last picture. So this is the plan for Delhi, as I told you. In the recovery shelter, we'll station an ultra-portable X-ray and TrueNut, and this will become a medical facility for the homeless population in the vicinity, both those living in the shelter and those outside.
All right. Good morning, good afternoon, good evening, everyone.
Okay, now we break for lunch, and I'm sure all of you are looking forward to it, but we've got enough food for thought in this long morning session. Yes, okay, Bianca will make some announcements also, but get ready for lunch now. I just want to inform that since the bus can only fit about 30, so we have 68, interested participants. Yay! Unfortunately, we all cannot fit into the bus. So if we can break into two groups, the minute that you finish your lunch, the bus is already waiting, so we can take the first group of 35, and then the bus comes back and picks the other group. Would that be okay? So the minute you're done, you're okay to leave, please get into the vehicle. Yes? Yes. Yeah, I think the ones who are ready, sit in the bus so you get your spot. Well, when you're done with lunch, so what the time? I don't know how much time do you need for lunch, but at least 40 minutes. Would that be okay? 30 minutes? Some are saying 30. Okay, the ones who are ready, as soon as they're lunch, sit in the bus, so it can already leave. So whenever you're ready. Thank you. For the ones who are not going to the visit, please wait in the reception area, and we'll arrange another vehicle. Thank you. Just again, tomorrow, the ones who are staying outside of Kenilworth, the bus will leave at 8:30.